Hello, good evening, everyone. Hello, can you hear me? Can you see my slide?
Yes, sir. Good evening.
Oh, all right. Yeah, good evening. So can we start, please?
Yes, sir. Good evening, sir. We can start, sir.
Oh,
We
all
can
right,
start.
sir. Thank you, sir. Yes, sir. All right. Good day, everyone. It's lovely to connect with us all, and thank you all for joining. And big thank you to our organizers for putting things together for us. So let's get started. So today is going to be on. So it's going to be on the rib fracture and traumatic abdominal injuries management from physio point of view. So everything we'll be talking will be based on physio management, risk identifications, how we can help patients to prevent complications, and evidence-based management. So last week, I thought of bringing this up because last week I think we had discussion about around cardiothoracic surgeries. So we're able to cover surgeries related with heart. So I would just encourage us to maybe go over those teachings again. So there could be a kind of carryover of knowledge because some of those things are also quite related to what we'll be discussing today as well. So, all right, so let's get started. The first thing here is on anatomy. Of course, we are not here to discuss anatomy. We are here to discuss about physiotherapy, management, and all of those things. But and again, I believe we all had good basis when it comes to anatomy, of the thorax, anatomy of the ribs, tendon, breathing mechanics, and physiology of breathing and all of those things. So we won't sit down and start analyzing those things, but what I feel is quite very important that we need to remind ourselves again that is really, really very important to us when it comes to physio management of patient with traumatic rib fracture or chest injury. So we need to remind ourselves about these two mechanisms of breathing, which are the pump handles and the bucket handle movement of the thoracic cage of the ribs. So the pump handles, just like the picture we can see here. So the pump handle is just the upper segment of the ribs, around ribs 2 to 6, being involved in that. And what they do is just to increase the AP dimension, the front and back dimensions of the chest, between the breastbone, the sternum, and your vertebral bone behind. It's just to increase the dimension of that. So what that happens, we won't sit down and start analyzing what muscles is involved, what nerves is triggering that, and all of those things. It's not very relevant to us here, but we need to remember this as physio. And the other thing here that we also need to remind ourselves is about the bucket and do, the transverse dimensions of the lower rib cage, the lateral dimensions of that lower rib cage, just to improve the, during inspiration, so that by the time your chest move up, and you also want the lateral dimension as well to also be increased. And why is this very important to us as physio? That is what we need to now discuss, not the in-depth of the anatomy. So why is this relevant to us as physio, and what is the benefit of this? The simple answer to that is, during inspirations, we all know that inspiration basically is an active process. Your diaphragm will descend. You want the thoracic cage to be bigger. You want that cage, that area to be bigger as much as you can, so that air can fill into the lungs. So the role of these two mechanics is just to allow the upper body part, the upper part of your chest region to be wider than enough, and you also want the lower side as well to be also be to be well opened as well, so that air can easily fill into the lungs. So now, in case of refracture, now in case of trauma to the chest, so now, if I may ask us, so how do we think this might be a big issue to our patients? What kind of things do you think? How do we think this might impact this impairment in this thoracic movement, the upward and outward, or the lateral movement of the chest? How do we think that might impact our patient? I think that is what we need to be discussing here. If I may ask us to quickly share our knowledge on that, so I think we can start with that. So what do we think? We know from our basic anatomy, the mechanisms of breathing, inspiration, expirations, all of those things. And again, we have reminded ourselves about the two major pump that we need to remember, which are the pump handles and the bucket handles. And the role of these two is just to make the inspiratory breath to be bigger enough. You want the chest to be wider enough so that air can fill into those lungs as much as possible. That is just the basic mechanism about these things. Now, how about if somebody have got a trauma to the chest? This movement, either pump or either bucket handle or pump handles, is being impaired. So what kind of things do we think might happen to that patient in the long run? So how do we think that impairment might impact our patient? Hello? Is anyone able to help us with that?
Okay, good evening, sir.
Yeah, good evening, Ma. Yeah, go ahead.
Okay, so they won't be taking their full deep breath, they won't be expiring deeply. So the diameter will be reduced. So the amount of air that they are meant to, that is meant to inflate the lungs, will be reduced. So they will be impaired, or it will be reduced ventilation. Not that the air cannot enter, but because of the pain that they are avoiding, there will be respiratory splinting because they don't want to increase the pain. So the breath will sort of be shallow.
Yeah, great job. Perfect. Thank you very much. So that will be that shallow breath. They won't be able to take in big breath as much as they can. That is really very important. So in our patients, we go to their bedside because of now they've had a trauma to the chest, they are in pain, they are not being able to take in deep breath as much as they can. So we may likely see them, we may likely see that rapid shallow breath at their bedside. Great job. Thank you very much. That's really, really lovely. So what other things should we be expecting? Because this is physio, and we need to build our reasonings around what to be expecting, around how are they likely to be presenting, and all of these things will also be needed to guide what we'll be doing with those patients. Yeah, Peter, excellent. I've written in the chat box. Yeah, good evening. Go ahead. Yeah.
I think the breathing will be painful. The breathing will be painful as a result of the movement. And well, I also agree with the shallow breathing.
Yeah, thank you very much. Really good stuff. Really good stuff. Excellent. Of course, the breathing will really, really be very painful. And again, we can also link that to anatomy as well. In the chest as well, you've got nerves, you've got intercostal nerves, you've got everything, vascular bundles, and all of those things also in the chest as well. Their names are not really important. Honestly, cramming those names is not gonna. But what really matters is the patient clinical presentations. What you want to really be doing to them. honestly. Now, again, somebody, they've got a trauma to the chest. There might even be an irregular, abnormal movement of the chest. And again, the chest movement again might also be, might be irritating those nerves. All of these things might also be contributing to their pain. So just like the PT said, their breathing also can also be very painful, really, really very painful as well. Thank you very much. Brilliant stuff. Yeah. Can we have more physios on board to speak about these things? What are we likely to be seeing at the bedside? People have mentioned painful breath. People have mentioned shallow breath as well. So what other things should we be expecting at their bedside? Because these are the reasons that will definitely impact whatever things we're going to be doing with this patient. Yeah, let me quickly read the chat box. Peter, excellent at everything. That will be impaired lung breathing mechanics. Yeah, that might be that abnormal breathing mechanics. Normally, what we expect during inspiration is we expect the chest to go up, to move upward and outward. We expect that, that because you want to feel in here into your lungs. So sometimes you might go to some patient bedside because of the nature of the injury they've had, because of the trauma to their chest. As opposed to the chest rising during inspiration, their chest might be shocking in, their chest might be collapsing in. We're going to talk about those things. You can find that in patients. Yeah, really good stuff. Thank you for that. So, PT Deborah, there will be decrease in lung volume. Perfect. Excellent stuff. Good physio stuff. Great. You go to their bedside, somebody not being able to take in that deep breath, that big breath. They are struggling because of pain. They are struggling because of their trauma to their chest. What will happen in the long run? The lower lobes, the alveoli, those smaller airways, what will happen? Those alveoli, they love air. But before you know, ears start getting depleted into those alveoli. Ears are struggling to go into those alveoli. What will happen in the long run? They start closing up. They start closing down. The FRC start getting low. They start closing down. Good stuff. Thank you for that. Yeah. And again, in terms of exercise tolerance, it's also written that, they make them to have reduced exercise intolerance, reduced exercise tolerance, which is great. Great. Because how is exercise tolerance linked to these things? Because we know, again, for somebody to participate well in therapy, for somebody to participate well in anything physio, you need your lungs mechanics. You need good breath. You need to be able to take in good breath. You need your everything, your cardiovascular system as well to be working well. If somebody is not taking in good breath, they might even be they might be having increased work of breathing. Their respiratory might be really, really very high at that moment. They won't be able to participate well. Great stuff, good stuff, brilliant. Yeah, poor trunk movement, perfect. Yeah. Their trunk will not be moving well. There might be some paradoxical, abnormal movement of the chest. Yeah. Keep popping in those responses. Yeah, lung collapse is also another thing. Yeah, lung collapse. Air is not air is not sinking well into those lower lobes. What will happen? The lungs will start closing up. And we know the implications of this. Yeah. So what other things do we expect at the bedside? I know we've got a bunch of these things, but let's talk about them before we move forward. This is what matters to us, not those big anatomy names. Yeah. Go on.
Okay. They will be avoiding like coughing, because with coughing there will be increase in intra-abdominal pressure. So they might obviously be having secretions. So you may need to teach them assisted huffing and coughing techniques.
Oh, super stuff, super great stuff. Thank you very much. I love that. Yeah, somebody struggling with pain, somebody, even pain avoidance is another thing. They won't want to take in deep breath. And it's really, if we've really seen patients with chest trauma before, they are really, chest pain trauma is really, very, very painful. They will do everything to avoid taking in deep breath. And again, remember, when you talk about cough, we talked about this thing last week, 3 phases: inspirations, glottal closures, and your expiratory phase. If somebody is not having a good inspiratory flow, you are not feeling your air into your lungs appropriately, what will happen to the flow? That pressure will not build up nicely in your glottis. And what will happen? That expiratory flow will also be poor. That you can have that clinical reasoning. Aside from that clinical reasoning, you can also reason this way: somebody doing everything to avoid cough. And don't forget our first line of defense when it comes to our airway is cough. Cough is our first line of defense. And as physio, cough is really, very important to us. Somebody doing everything to avoid coughing. What does that mean? Secretion building up in their chest. What will happen? Bacteria, they love those environments. They love anaerobic environment. They love those areas. What will happen? Bacteria start living well. They start feeding well in those anaerobic environments. Before you know, chest infections, chest infection setting. Before we know, what is the implication? Rise in oxygen requirement, 40, 60, 80, if care is not taken. So really good stuff. Thank you very much for that. So because of many reasons, patients might avoid coughing because of poor inspiratory flow. That will impact on their cough. And again, because again, coughing again will also impact, will also cause more pain to them. So patient will do everything to avoid those things. Really good stuff. Can we have more stuff here, please? Yeah, let me read the chat box again. Yeah, lung collapse. Thank you. Yeah, Pretty Stella, bleeding in the lungs due to fracture, puncture, or defense. This is another big thing again that we need to be thinking about these things before we go to their bedside. You got the referral or you pick them up. Like we always said, we are working towards being able to pick up patients, either trauma patient, either surgical patient, either medical patient, being able to look at our criteria and say, yeah, this patient needs physio. Rib fracture patients also need physio. They need physio. We don't have to be prompted by the doctor. You don't have to, ideally, they need to be seen by physio. All right, because we know the complication. We know what may happen if we don't get to see them. We're going to talk about evidence-based, how we can support this patient. But let's go gradually. Let's build those clinical responses. Another thing we need to be thinking about, just like Stella has written here, bleeding. Yeah, we can have, some patient might have trauma to the chest, the rib fracture might puncture the heart, might puncture the lungs, it might puncture the neurovascular bundles, the arteries and everything. We know all these things. So what will happen? Some people might have internal bleedings. And even some patients, if you have seen, some elderly patients might even be on anticoagulant, maybe they normally have warfarins and all of these things. Puncture to their chest again can also increase the risk of bleeding and all of these things. Great stuff, good stuff. Good, great. Thank you very much. Yeah, reduce, PT Ruben, reduce mobility and poor positioning in bed. Yeah, really good stuff. I love this. Thank you very much. If you go to their bedside, you go to see patients with chest trauma on the bedside, what happens? They are struggling in pain. They are groaning in pain. Pain, very, really, very, very, very big pain. What happened? You look at them in bed. You need to be aware of them in bed. You normally find some of them slump in bed. They are slump in bed. And you know that what that means to us as physio. Poor positioning. What happened to poor positioning in bed? Reduced functional residual capacity. Not being able to take in deep breath. That will also make it more difficult for them to take in deep breath. Because like I mentioned last week when I was talking about cardiothoracic, somebody standing, normally, this is how respiratory physios or chest physios, this is how we think. Somebody standing is better than somebody sitting. If you are sitting, it's better than when you are sitting up in bed. If you are sitting up in bed, it's better than somebody lying in bed. This is how we're reasoning. Now, if somebody is now lying in bed because they are groaning in pain, the pain is really terrible, their pain is not optimized, they will have reduced poor positioning in bed. Their positioning is not going to help them. It's not going to, even thinking about building up pain tolerance is not going to help them. What do we do? This is start thinking about this. Reduce mobility. They won't be compliant. Like I used to say, as an acute care physio, you've got little, when it comes to pain management, we've got little stuff to be doing. We don't have those modalities, but we've got our compassionate, we've got our non-soft skills together with MDT, so using MDT to help patients to manage pain. Unlike outpatient, you can do stuff, you can do hands-on stuff, but in acute hospitals, somebody struggling in pain, you can only use soft skills, pain medication, and all of those things to help them. So they won't, pain is your worst enemy. Pain is your worst, your number one enemy in acute hospital is pain. So how do you manage that pain? If they are struggling in pain, they won't tolerate, they might be struggling with mobility. They might even be struggling with positioning in bed. Think about all of these things. Great stuff. Thank you, Pretty Ruben. Pretty Stella, mucus retention. They start retaining. They are not able to take in deep breath. If they are not taking in deep breath, what happens? There's a concept called collateral ventilation. Collateral ventilation. What does that mean? Getting here behind the lungs. Sorry, getting here behind the mucus. Somebody is not being able to take in deep breath. Here will not get behind all these. Some of our physio skills are just collateral ventilation. All this deep breathing you tell patient to do. All this ACBT you tell patient to do. All this autogenic drainage you tell patient to do. They work with collateral ventilation. That is the concept. Getting here behind those mucus, using expiratory flow to mobilize those secretions from peripheral airway to the central airway. Then use your cough to clear them. If your patient is struggling with pain, they won't be able to take in deep breath. They won't be able to clear the airway. What happened? Mucus plugging. What happened? Increased oxygen demand. What happened? Their CRP will start jumping up. Their white blood cells start jumping up. What does that tell you as physio? It tells you that now we are dealing with chest infections. Great stuff, brilliant physios. Thank you very much. Let's move forward. We can go on and on to think about many things, fantastic things, building up those clinical reasoning before we go to their bedside. This will help us when it comes to their management and all of these things. Great stuff. Thank you, everyone. Let's move forward. Yeah. Another thing here I really want us to think about is in terms of peds and adults. It's not about talking anatomy, big names. No, relate those anatomy to your physio. Now, think about peds and adults. Generally speaking, when it comes to peds, we all know kids, their ribs are still developing. Even when it even comes to ribs compliance, their ribs is more very compliant. Why? Because most of their ribs cage are still cartilaginous, they are still developing. So if you look at respiratory rate in kids, let's make it practical now. Newborn baby, for instance, look at their respiratory rate is higher than adults, right? And again, when it comes to their ribs, the orientations of their ribs is more horizontal than that of adult. Adult is still more conical in shape and all of those things. What does that mean to us? What does this thing mean to us? Have we ever thought about these things? What does it mean to us as physio? Let's have some clinical reasoning here as well. What does those things? Does it sink anything to our brain, or does it stimulate anything into our cerebrum? What does it mean to us as physio? What does those mean? So, okay, let me first say this to make it very easy for us. Like I said, newborn baby or kids or peds or something, their ribs are more horizontal, which means tentatively, when it comes to that bucket handle, that lateral dimension, that transverse dimension is not really there for peds. It's not really there for peds. For adults now, we've got that bucket handle movement. Our thoracic can go high. We can feel in our lungs. That lateral dimension is there. But for peds, that bucket handle movement is not very great in peds. What does that mean for us? Let's say you are being called in now, you are in physio, they call you in the middle of the night. We've got a ped, we've got this year, 5 years old or 4 years or something. They are desaturating, they've got trauma to the chest, or maybe they've even got, let's say, congenital issues in their chest or something. And in your head, you are trying to build up some of these clinical reasonings. So what does this thing mean to you as a physio going in to treat that child? What does that mean? What does that thing mean to you? Is this sensing anything? What does it mean to us? Peds not having bucket handle movement. Peds not having that bucket handle movement. Peds having that, what's it called? Horizontal rib orientations. What does it mean? What does it mean to them? If you compare that with adults. And again, if you compare their compliance, their ribs is not very compliant. That is why you find their respiratory rate going higher and down like that, rising, quick rise, quick fall, and something like that. What does that mean? What does it mean to us as physio? What does those things mean to us? Can we get some clinical reasoning kind of discussion here as well? I will sit there, please. Can you hear me? Hello?
We can hear you, sir.
We can hear you, sir.
Thank you,
All
sir.
right, thank you very much. Thank you very much. So can we have some discussion around this part too? Let me repeat myself. Peds I know peds are they are specially made people. No, even when it comes to their treatment. Don't worry, we still to discuss about peds in detail. When it comes to their treatment, oftentimes even myself, if I get some calls to peds or something, maybe in the midnight to come and treat, I'll be like, wow. No, you have to just be careful. So this is one of those reasoning you have to have at the back of your mind when you are treating peds. Their ribs are horizontal. They've not got that bucket handle movement. What else again? Their thoracic cage is more compliant. What does that mean to us? Beyond damning anatomy and all those things, it's not about that. It's about those clinical reasons. Yeah, let's get the chat box. Anything we can just, let's see. Reduce lung volume, perfect, pretty stellar. Reduce lung volume. If somebody don't forget, we mentioned to ourselves that lateral dimension expansions is just to increase the lung volume together with the pump handles. But in peds, because they are still developing, that thing is lacking. What does that mean? So it means, again, if you compare in terms of lung volume, generally speaking, of course, they are still baby, their lungs is still developing, even still developing as a whole. So in terms of lung volume, of course, their lung volume will be reduced. Great. What does that mean again? So if we link it to your tidal volume kind of things, I'm speaking too much of this thing. Now, if you tidal volume is just I'm breathing in, I'm breathing out. Normal tidal volume is just no big, not big something. It's just the normal breathing we are doing right now. Nobody is having any respiratory distress. We are just breathing normally. No labor breathing. We are not on oxygen and everything. This is tidal. We are just using our tidal body. We are breathing in and out. If you look at that in PED, because they've not got that lateral coastal expansions. So what does that mean? It means again, they have reduced, normally they will have reduced tidal volume, which means if you are treating them, if you are at the bedside, you are treating a PED, they can quickly fatigue. Be careful with them. As opposed to adults. Even adults too can quickly fatigue depending on their background and presentation and everything, but adults can still compensate. I don't know if this thing is making sense. Adults can still compensate. They've got that compensatory mechanism to cover up a bit. But in PED, that is why you need to be very clear when it comes to your treatment selection in treating PED. Oh, what am I doing with this PED? Okay, yeah, I'm gonna do vest therapy with them. Okay, what am I doing with this PED? I'm gonna cough assist them if there is indication for it. What am I doing? It is not sometimes doing try and error when it comes to PED might really fatigue that kid, and you might end up not doing anything for that PED, for that child. Think about that. You are being called in, or you are going in to treat a PED. Think about those things. Oh, I'm treating a small child now. Oh, they lack that compensatory mechanism. That means they are only breathing through their diaphragm. Diaphragm is the major respiratory, as opposed to adults. You've got that, what you call intercostal muscles, you've got compensatory, you've got this thing. But in PED, that thing is lacking. Think about that. What does that mean again for us as physio? In terms of okay, let me read before I added mine. Let me read what people have written here. PT Stella, thank you for that. I appreciate that. PT Igbinoba, sorry, I'm just PT Messi. Yeah, they will have reduced inspiratory volume. Perfect, 100%. Reduced inspiratory volume. So that means, again, think about it. They've got a narrow airway. Their trachea, everything is very narrow. Again, they lack that lateral intercostal expansions. So which means their inspiratory volume is low. It's very low as well. In terms of respiratory rate, again, they can quickly, because they've got a very small airway and everything. So you've not got that compensatory that can make the breathing more longer than expected. What do you expect? Here we go in and go out, go in and go out. So you think about those things when you are going in to see them. All right, let's see again what people have written here. They are at risk of respiratory distress. Perfect. Thank you very much. Big one I've been looking for. This is PT Grace. Thank you very, very much. I love this. They are at risk of that respiratory distress. They fatigue very, very quickly. They've not got that compensations. That is the language, respiratory distress. Think about those things. So you need to think about, oh yeah, I'm going in to treat them. What am I doing? So in terms of respiratory distress, what do we see? What do we see? If you can pop that in the tab, I will appreciate that as well. What do we see? You can see, let me just tell you one of them. What do you see? You can see their rib cage shocking in. You can even see trachea recessions. Trachea. You can see that trachea recession. If you put that, or you can check if you put that on Google, you can check the picture or videos or something on that. You can see trachea recessions. You can see what is it? Sternal recessions. Their sternum will be shocking in. This is respiratory distress. You need to optimize them. Otherwise, that kid might pass away. They need oxygen. They might need oxygen. You need to optimize them. That is what it means. As physio, we need to be able to identify some of these things, because you go into their bedside, you might meet them doing well and everything, you just do small treatment. They go into respiratory distress. What do you want to do? You will leave them. Don't be panicked. You are a clinician. Yeah, put the call bell, depending on your skill set or something. Put the call bell, but again, put the emergency bell. But again, be confident and build your clinical reasoning. What is this thing? Think about those things. Yeah. All right, let me see what people have written again. Yeah, reduce inspiratory capacity 100%. Thank you, PT Sonny. PT Excellent again. Can easily desaturate. This is another big thing. They desaturate very, very quickly. They desaturate very, very quickly. And again, let me say this. I used to tell people, you are going to treat a PED. This is how we reason things. Prepare your non-rebreathed oxygen, your non-rebreathed oxygen. Prepare that at the bedside. Because any small thing you do, they might just desaturate. Their saturation will start dropping. You need that emergency oxygen to pop on them, just pop it on their face. What will happen? That they will quickly start coming back again. They quickly start coming back again. This is how this thing works. You cannot be a good pediatric physio, either on physio or whatever you are working, or based in acute physio fit care. And if you don't know all these things, I wonder, two things are involved. Is either you are not doing your job well, or you are just running away for your duty. One of those things will happen. You need to know these things. If you really want to be an excellent physio, doing your job well, doing everything possible to help your patient, you need to know all these things. Prepare your non-rebreathe. Aside from oxygen, even sometimes you just go to their bedside and just do any small thing, and you just, the heart rate might also start dropping down. What do you do again? Pump that oxygen again. Because I will explain those things, the concept later on when we get to PIDS, so that I won't be diverting too much. Because again, PIDS are likely to die of respiratory arrest. This is one of the reasons we are talking to. They are supposed to adults. Adults are likely to die of cardiac arrest. We explain, we differentiate adult and PIDS by the time we get to PIDS. But a few more things, let's see what people have written. They need, this is P.T. Ruben again, thank you. They may need assisted breathing techniques. Yeah, they may need that. That might be the case. Yeah, they might need something to compensate for that, for their breathing, depending on how they are presenting. 100%, thank you. P.T. Ruben, high metabolic rate. Yeah. I love this stuff. Yeah. Nasal flare. Yeah. PT Grace. Yeah. PT Grace are popping a lot of signs we should be aware of as physio when you are the bedside treating P. She's written flare, nasal flare. You just find your nose going wider. These are signs. You should be able to pick that up. Subcostal recession, 100%. Think about that. Subcostal is just between the ribs now. Between the ribs, the space there. You just find the space shocking in. Should be able to identify that as physio. Intercostal recessions, yeah. Subcostal is below the rib cartilage. Sorry, below the lower ribs. Yeah. Intercostal recession is just between the two ribs. You find that shocking in. Tracheal recessions. We need to be able to identify this. Thank you very much. On the head bumping, grunting signs. Oh my God, lovely stuff. Really appreciate that, PT Grace. I love that. Perfect. So now we need to be able to identify all these things. And we need to be able to link that anatomy to our physio. Not big anatomy, no physio. That does not make sense. In fact, I like no anatomy or little anatomy, big physio. We are physio, we are no anatomists. We are physios, not anatomists. All right. Now, the other thing I mentioned the other time that I would also like to, before I come out of this slide here, that I mentioned is, in terms of their rib compliance, their rib is really very compliant. What does that mean? You know, there is this concept we used to do as physio. We used to do bad lungs up. Are we still there, please? We used to do bad lungs up. Like, oh, you go to patient. Yeah, let's say they've got right-sided collapse. We love that positioning. You put the bad lungs. Oh, put that bad right side, put it up so that they can ventilate. Yeah, great stuff, good stuff, brilliant. Do you know that bad lungs up might really be difficult for your PED patient? It might not be that best position for your patient. Yeah, for the pediatric patient. Do you know why? Let me tell you. The reason is this. Somebody have got, let's say the child have got right-sided lung collapse. That means they've only got that left side now. The left side is the good side now to be breathing, to be ventilating. So now you now go to their bedside. You now put that good side, you make them to lie on the good side. You now put the bad lungs up. My colleagues, sometimes that position it makes the breathing, it makes it much more difficult for the PED to breathe. The reason is this: by the time the good side now is the side you have put down. The bad side is the side that is up. So now they struggle, most of them struggle to use that. They won't be able to use the good side because the good side, don't forget, their ribs are really very compliant. It's squeezy. Let's use that English. Their ribs are compliant means their ribs is squeezy, like easily squeeze their ribs. Let's use that English. Forget about compliance. Compliance is just modeling the whole thing up. Their ribs is really very squeezy, like squeeze the ribs. Now, if I'm now putting that good part of the lungs, I'm placing it down. What does that mean? I'm also squeezing that good part. So how do you want them to breathe? How do you want them to breathe? So think about this thing. Now, that does not mean I can't do it, but have that clinical reason in your head. If I do it, I watch their saturations. I watch how they are compliant. I look at their physical signs, all those things you guys have listed, those brilliant stuff. I watch for those signs. I look at their saturation. I look at their heart rate, blood pressure, everything. Oh, if I'm not happy, if the saturation is dropping, I quickly think in my head, oh yeah, why is this dropping? Oh, that means that good side is getting squeezed. What do? You position them up. If the issue at that moment is just ventilation, reposition them up. Put that good lungs up and do whatever things you want to do with them. If this thing makes sense, think about these things. Like I said again, it's not about anatomy. It's about physio on top of that anatomy. If this thing makes sense. Does it make sense? Please let me quickly get feedback before we move away from there. Hello, is it making sense? Are we getting these things?
Yes, sir.
Yes, sir, we are getting it.
All right, thank you very much. Thank you very much for that.
We are with you, sir.
All right, thank you very much. Thank you very much for that. All right, we move forward. Let me see what people have written again. Yes, sir. Thank you, P.T. Ruben, P.T. Mulikat. Thank you very much for that. We move out of here. Yeah. So now, process of refracture. Let's discuss. We know these things. Our job is just to have clinical discussions. It's not style or this. Yeah. What are the causes of refracture? What can we think about in terms of refracture? Look at our country, Nigeria. Refracture, the patient we've seen in the past. Why are they having refracture? What could be the cause? Can you pop that in the chat box as well? Let's quickly discuss. And if we could put little things, if it is this, what is likely to happen? If it is this, I would also appreciate that. Yeah, let's learn from each other. Yeah. All right. What are the causes of refracture? Yeah, fall, road traffic accident, very common. Yeah, road traffic, blunt trauma. Yeah, blunt trauma. I love that. This is PT Ibrahim. Thank you very much. Really good stuff. PT, RT here. Yeah, road traffic accident. PT Grace, PT Idira. Good stuff. Blunt trauma. What does blunt trauma mean to us? Sometimes when you read caseload, you just find some, what is this blunt trauma? What does it mean? What does blunt trauma mean? What does it mean? Gunshots. Perfect. Yeah. Yeah. Great stuff. Great stuff. Brilliant stuff. Yeah. Keep popping those things. Yeah. Stabbing. Yeah. Physical assault. Perfect. Really good stuff. Yeah. Which other thing? Think about it. Think. Let's keep, what other thing can we find? And it cause trauma to the chest. What other thing? Yeah, boxing. Yeah. Very possible. Very, very possible. Very possible. 100%. Great stuff. Think about it. What other thing? Yeah. What other thing? Yeah, osteoporotic fracture. Perfect. 100%. This is PT Lukman. Thank you very much. I appreciate that. Yeah. Blunt trauma, PT Grace again. Yeah, blood trauma is a non-penetrating injury. 100%. Non-penetrating. You might not even find anything. Not like if you stab somebody now, for instance, that would be a penetrating injury. But for blunt, yeah. You'll find that. Yeah, great. Yeah. PT Bashir, yeah, coughing, excessive coughing and sneezing and all of those things that can impact. Great stuff. If you find somebody with, let's say they've got osteoporotic fractures or they've got any pathology or anything, they've got cancer to the chest or anything like that, yeah, anything can fracture. You can fracture your ribs, yeah, 100%. Surgery, yeah, surgery as well. We had discussion about cardiothoracic last time, yeah. Sometimes you might need to do open heart surgery for somebody. Sometimes you have to retract their ribs, you have to break their sternum, they use saw to break and all of those things. That's it. Also, fracture is fracture. Either iatrogenic or whatever it is, fracture is fracture. Perfect, 100%. I'm enjoying the way we are reasoning, not a pathogenic fracture. Another one, this PT Fauzat. Thank you very much, 100%. 100%, thank you. There are a lot of things we can keep thinking about that may cause fracture. Yeah. Let me read more. Yeah. Sport injury. That is another one. Sport injury. Thank you very much. That's PT Mulikat. 100%. Thank you. All right. So we can find trauma. We can find pathogenic, and this fracture might be displaced. It might be undisplaced. It might be flare-it. Flare chest is another thing we need to be discussing about. All right. Blunt trauma, just like PT. I can't remember. I'm sorry. Just as the PT mentioned, blunt trauma again is non-penetrating injuries. Non-penetrating, we need to remember that as well. Yeah, really good stuff. So we have already mentioned all of these things. But what I would like us to remember again is, beyond refracture, there might be some associated injuries. There might be some follow-up injuries with that. There might be like That chest trauma may also come with another thing. What are those things? But they might come with sternal fracture. They might come. It might even be upper limb injury, fracture, radial sternum, blah 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 fracture, humeral fracture. You can find somebody with tibiofibula or ankle fracture or something. We need to be aware of these things. The fact that they've called you to come and see them for their chest. To come and see them because they are desaturating, they are not saturating well, they are struggling to clear their airway, they have not been out of bed, or they've not. Aside, beyond that, when you are reading their notes, you should also pay attention to other area. Everything matters. Everything. This is a trauma patient. Look at everything. Oh, I think got trauma everywhere. You might find people with chest injury. They might have, what is it, basal skull fracture. You might find fracture anywhere in the body, pelvic fracture, this fracture. Pay attention to those things. So when you're also reading their notes, you're also reading, oh yeah, you're also reading, oh, they've got fracture, radial stellar fracture. Oh, what have they said? What is their current management? Are they to weight bear? Are they not to weight bear? Think about those things. Somebody might even find fracture. They might also have vertebral fracture. They might have what do you call it? They might have fracture to the cervical region, thoracic region, and those things. Think about those things. So now, if somebody has also got fracture to their sternum, to their backbone or something, what do you want to do? You also want to clear those areas. Let's say, for instance, now you are going to their bedside. What you are thinking about is mobility. Do you just go in and just mobilize somebody that have got fibular fracture with their chest fracture? You need to clear that. What is their current mobility? Are they for what is it, intermedullary nailing or whatever things, or are they for conservative management? Think about those things. Look at their operation, look at their note, look at their medical note, look at their surgical note. If they've had a surgery or whatever, look at it. Look at the post-op instructions. This is how we think. Thank you very much. Let's move on. Now, if I ask us again to talk about the symptoms. Now we've got a patient. They've had ring fracture. So what symptoms again? I know we have mentioned some of those things the other time, but we can still pop in those things again. Yeah. So what symptoms should we be expecting? Well, in terms of presentation, how will they be presenting? How will they be presenting? I'm going to need to see them now in my head. In my head now, what should I be thinking about at the bedside? So what should I be thinking about? Are we happy to put that again in the chat box again? Let's see. What am I thinking about? Yeah, let me see. Yeah, chest pain, pain, PT Ruben, PT Fauza. Yeah, well, that thing. Reduce oxygen saturations. Yeah, great. That's pretty great. That's 100%. Reduce oxygen saturations. Fine. They can't take in deep breaths. Yeah, paradoxical breathings. Yeah, if they've got flat chest, you can find paradoxical breathing. Their chest region is supposed to be moving up on inspiration. Their chest region is shocking me. Tenderness over the rib, really very sore, very painful, very tender. Perfect, great stuff. Tension pneumothorax, 100%. PT Fauza, yeah, great stuff. You can find pneumothorax. So now, if I'm going to treat them, I'm looking at, they've got chest trauma. I have to look at their chest X-ray. I have to look at their chest X-ray, rule out everything rulable. The pneumothorax, pneumothorax, pneumothorax. You can even find people with two. And again, not just looking at those things. Think about it. What is the medical management of those things? Are they for chest drains? Are they for conservative management? All pneumothorax is not all pneumothorax that they need to pass chest drains. It is not all pleural effusions that they need to pass chest drains. They might just say, yeah, for conservative management. Great. If they said for conservative management, it is now left to us as physio to help that patient to optimize that chest, to prevent secondary complications, to prevent the risk of that chest deteriorating. This is our job. Pleural effusion. Thank you, Stella. Shortness of breath. They are not taking deep breath. They are rapid shallow breathing. All of those things. Great. So I'm not just looking at the physical bit of it, or I'm paying attention to everything. Now they've got chest trauma. I know there is potentially they might have associated injuries like pneumothorax, like pleural effusion, like pneumothorax, like anything. I have to look. They might even have puncture to their heart and everything. I have to pay attention to medical notes, ensure that everything is all right before I go to their bedside. In terms of just like we've been saying, in terms of thank you. In terms of symptoms, pain, your number one enemy. Remember, your number one enemy. Shortness of breath, difficulties in breathing, impaired oxygen requirement, Some people might even be coughing up blood. It's possible. You can have people, of course, irregular heart movement, yeah, swelling, bruises, sore chest, everything is all there. Great. Thank you. In terms of complications, we have mentioned them: sputum retention, flex ligament, volume loss, respiratory failure is another thing. Yeah. Respiratory failure. Yeah. Let me see again the chat box. Somebody have written something there. Yeah, empyema, pause in the plural space. You can find that as well. Really good stuff. Thank you, Peter Stella. It's really, all these things are possible. These things are possible. So when I'm reading the notes, I'm paying attention to every details. I'm putting that into my own physio judgment so that I know, yeah, I need to go to the best. I need to do this. I don't have to do this thing. This is how we think. Respiratory failure. I was about talking about respiratory failure. Respiratory failure. Can we have discussion about this? How can these people have respiratory failure? And what kind of respiratory failure are we talking about? If it is this, it is that. How? If it is one, if it is two, how? How can they have respiratory failure? Let's talk about this thing. Yeah, I would love those comments in the chat box, please. Please put those comments in the chat box. Let's look at those comments. How can they have respiratory failure? How? How is it possible? Let's say again, because you might get that call, they might send that referral to you, they might you might even be the one picking them up, they are struggling, they are now going into respiratory failure. How will they know that somebody is now heading towards respiratory failure? And what are the causes of that? Let's have a discussion about this. I'm reading the chat box, I'm already there. Yeah, what do we think? What do we think? What do we think? This is physio. This is really, really good physios. Yeah. What do we think? How can somebody have respiratory failure? Somebody with chest trauma, blunt injuries or stabbing or whatever these things. How can they have respiratory failure? Are we still there? Are we still there? Just double checking. Are we still there, please?
We are here, sir.
Yes, we are here.
All right. Thank you. I appreciate it. Thank you. Let's see what PTs have written. Yeah, PT Messi. That's gone up. Yeah, PT Messi. We know by saturation of oxygen in the blood, SpO2. Yeah, PT Messi have written by the oxygen in their blood. What is that? ABGs. You need ABGs. ABGs will tell you their blood gas. We have had discussion previously in the past about ABGs. Go back to those things. There must be carryover of knowledge. Go back to those things. For us to know that somebody is tilting towards respiratory failure, we need ABGs. And even before they start tending into those pathways, what are the things we can measure on the wall? We can see, of course, it is written SpO2. The SpO2 will start, they will start desaturating. The SpO2 will start getting out of normal. The oxygen requirement will start going up. They will start needing a lot of oxygen to maintain SAT. And some people can even be struggling. Thank you very much for that, PT Messi. What other thing can we find? Let me see. Yeah, CO2 retentions. Thank you very much, PT Excel, PT Chidera. People can start retaining CO2. Again, how do you know that? We can't physically look at somebody and say, yeah, you are retaining CO2. How do we know again? Blood gas, ABGs, or venous blood gas, whatever, which one? Blood gas, anyone. We can know that. CO2 retention. How do we know that again? Again, you can also know by some signs again. Yeah, let me say that. You can know if somebody is retaining CO2, some people might start complaining of headache. That can be a pointer. Somebody might start sleeping more than normal. They might start feeling drowsy. But again, in terms of their chest movement, imagine somebody have got chest trauma, cramp to their chest. Their respiratory rate is high. All of a sudden, they start getting tired. Their ventilatory pump start getting tired. Of course, if somebody has got high respiratory rate, heart rate is high, respiratory rate is high, their breathing will be up and down, and at some point, what will happen to that person? The person will start getting tired. By the time they start getting tired, what will happen? They won't be able to breathe out. They will breathe out less. By the time they start breathing, I'm just putting this in a very simple way. By the time they start breathing out less, what happened to them? They start retaining CO2. They start getting tired. And what will happen in the long run if they start retaining CO2? Oh my God, they can be tipped into respiratory arrest, coma. They will die. Some of those things you can find, like, let me repeat again, for CO2, you can find flapping tremor. Someone now might start starting shaking. Some people might complain of headache. Some people might, I'm just talking of CO2 generally now, CO2 generally. Some people might start talking, no, what's it again? Some people might start complaining of headache. Some people might be sleeping than normal. But generally speaking, what you find in the case of chest trauma, generally speaking, most of the time is their presentation is normally high respiratory rate, they start getting tired, they start they start feeling drowsy, and before you know, you run ABG on them. After you run ABG, maybe after an hour or thereabout, their CO2 will start climbing up. What does that mean? Oh my God, we need to do something. We need to do something. MDT need to do something. If you are the physio looking after that patient, you are at the bedside, flag that. If you don't flag that, you are a bad physio. You are a bad physio. MRTB should be investigating you. This is how we think. Great job. Thank you very much. Yeah, PT Messi again. We know by the saturation oxygen in blood. Thank you very much. 100%. Yeah. We also know by, yeah, there will be work of breathing. Somebody is breathing too much. Yeah. No, they will no. Adult, for instance, your body is craving for oxygen. Your body wants that oxygen. All the compensatory mechanisms that your body have got, because oxygen is essential for life. What kills first? Let's talk about that. What kills first? Between oxygen and CO2, the answer is oxygen. Oxygen kills first. Oxygen kills first. Oxygen is essential for life. So now your body will do everything possible to get oxygen, because our body cannot naturally manufacture oxygen. We rely on the atmosphere to get oxygen. Our body cannot manufacture oxygen. So what will happen? You might find nasal flaring. You might find, you might find the heart rate going out just as you are breathing. Everything, your body, you find, what do you call it again? Your accessory muscles of breathing, they will kick in as well. Your sternocleidomastoid will kick in, your P major will kick in, your scalene muscles, everything will start kicking in. They will kick in. They need to be in action. They need to find those oxygen for you to be alive. Otherwise, and again, what happened in the long run? By the time those muscles kick in, and your body is still struggling for oxygen, and their body is still struggling for oxygen, what happens? Because normally we are not supposed to be using those accessory muscles of breathing to ventilate normally. Like your body cannot sustain them for longer period of time, because we need those high amount of oxygen to get them into moving. But what will happen in the long run? They start getting tired. By the time your patients start getting tired, what happens? Hey, we need escalations. If you don't escalate, something bad might happen. All right. So again, hyperventilation, this pretty Valsat, hyperventilation, respiratory acidosis. Of course, you can check, by the time you check their ABGs, respiratory acidosis, their pH might be going down, their CO2 might be going up. Yeah. Great job, PT Lukman. Here enters pleural cavity, causing collapse of the lungs, causing respiratory system. Perfect. Good, great stuff. Yeah, PT Mulikat, worsening chest pain, breathing is another sign of respiratory. Yeah. There is rapid, shallow breathing with your accessory muscles kicking in. These are all signs of that something is failing. The pump is failing. That is how we say it in acute hospital. The pump is failing. The pump is failing. We need to do something. Now, in terms of doing something, what are we thinking about? Let's start. Let's just small things. What are we thinking about? Somebody is breathing now. They are in labored breathing. They are labored breathing. Their accessory muscles are kicking. Everything is kicking. They are struggling at the moment. What are we thinking about? Let's say you are the physios now. You are the bedside. You are going to see them and you notice this. Of course, first thing first, what do? They are really struggling. You need to speak with the medical team immediately. You need to escalate that immediately. So in terms of treatment escalations, what kind of things do we think we can put this patient on to offload their breathing? Let me say that again. To offload, that language, very important, to offload their breathing, just to take it, just to give them that chance to pop them on that thing, and that thing can just make their breathing more easy, more comfortable for them, more comfy for them. What are we thinking about, physios? What are we thinking? We can just in time, because sometimes by the time you are speaking to the medical team, you have looked into their ABGs. Their ABGs is not. Oh yeah, something just popping into my head now. Let me say this. Sometimes there is this. I think I cannot really remember that page again. There was a time somebody put in a question on a particular page. And the question was, I think it's about refracture. I think it's about refracture as well. And the question there was, somebody came in with refracture and you run their ABG. What is likely for their ABG to be showing? I would also ask us those questions. Yeah, it was a very, very lengthy conversation on that page. I cannot even really remember that page today. Somebody had a chest fracture. They have a refracture. They came into the hospital and you run, let's say two things now. If you run the ABG immediately, what is likely that the ABG is likely to be showing? If you run the ABG, let's say after 1 hour, 2 hours, they are fatigued, they are tired, and you run the ABG, what is likely for the ABG to be showing? Did we get the question? Yeah, thank you very much, everyone. I'm reading the chat box. Yeah, oxygen supplementation. Yeah, thank you very much. I appreciate that. Now, but I'm putting in another question now. The question is, somebody have a chest trauma, a refracture trauma. They came into the hospital. Let's say we do their ABG immediately, just theoretical something now. We do the ABG immediately. And there is this another patient, after 1 hour, 2 hours, they are fatigued, they are these things. We run their ABG after that time. The first person, what is likely that their ABG will be showing? And for the second person, what is likely that their ABG will be showing? Okay, maybe I just leave us to start to think about those things while I continue the because of time. All right, because we still have much to discuss today. Thank you very much. I love our responses and I'm really, really very impressed. I'm 100% very, very impressed. I thank you very much. All right. So let's continue this. We have talked about respiratory failure. Of course, respiratory failure can be type 1 respiratory failure, it could be type 2 respiratory failure. And again, like we mentioned in the previous teaching, when we talk about type 1 is just oxygen issue, hypoxemia. Type 2 is just your oxygen problem and hypercapnia, less CO2. These things will be shown on your ABGs. And again, even before you run ABGs, look at your patient at the bedside. Are they having that work of breathing, increased work of breathing? Are the accessory muscles kicking? How are they presenting at the moment? Be able to pick up those signs and escalate as much as possible. All right, pneumothorax, we have talked about that. I think P.T. Stella talked about empyema, which is really great. Abdominal injuries, that is another thing you can find, complications. Another injury, usually you might find somebody with, they might say they have contusion or blah, blah, blah to the liver. You might say somebody has splenic lacerations. They might also have injury to their abdominal region as well. So not just ribs, you are going to see them at the bedside. They might have injury to those organs as well. All right, I think the second part of this presentation will talk about those injuries to the abdomen. So that's why I put two of them together. All right, complication. And again, let me say this. Ideally, evidence-based wise, physio-wise, if somebody have come in with a refracture, they are meant to be on your caseload. You should see them in the first 24 hours when they are admitted into your hospital, not when the doctor maybe the pain is now fully subsided. That is subsided. That's when they now remember there is one physio somewhere. Come and see them. That is a wrong practice. You are meant to see them the first 24 hours of their admissions, and at least they need to be on your caseload for the next 72 hours. You need to monitor them because patients with chest trauma, they can rapidly deteriorate and die. So this is why we keep saying, and again, who are we to blame here? Yeah, I need to say this. Who are we to blame? Is it the doctor that is not sending the referral? Or is it the physios in that hospital that they have neglected some part of their job? They can't go onto the ward, they can't figure out patient that need physio, patient that do not need physio. Who is to blame? Is it the doctor that was never trained to be a physio? Is it the doctor that was never trained to be a physio, that was never trained, that was not even aware of the recent physio evidence-based stuff? Are they the one to be blaming? And are they the one to be blamed? Let's think about these things. So when we say evidence-based is not sitting in the office waiting for referral from doctors. Stroke patient, they have admitted in the hospital, blah, blah, blah. They have been having medical distance. You are in the office. You have not gone to those wards to see them. So it is now when they are now medically ready, they are medically optimized. That is now they will now write a referral to you. What happened to that stroke guidelines that say see them in the first 24 hours of their admission? This is physio related, not doctor related. Who is to blame? Doctor. What happened to that physio? The office drinking tea. You have ignored your job, your duty post. So let's start thinking about how can we effectively do our job in acute hospitals. Let's think about those things. All right, let's continue. Yeah, let me read the chat box again. Maybe we've got some lovely stuff down there. Yeah, acute respiratory acidosis. Yeah, okay. The question I asked: acute respiratory acidosis, pH reduced and CO2 increased. Great. Reduce oxygen level in the blood for the second patient. Okay, PT. I'm struggling to pronounce this name now. Hugu. I'm sorry. Reduce oxygen level in the blood for the second patient. Let me think about that. Reduce oxygen in the blood for the second patient. Yeah, perfect. That will reduce oxygen in the blood for the second patient. Of course, because now they are in the hospital, they are fatigued, they are not breathing well, they are tired. Of course, there will be reduced oxygen in the blood. That is no doubt about that. Perfect. That's 100% very correct. Thank you for that. Let's move forward. I'll still come back to that question because it's what it is discussing. I'll still come back to that. I won't discuss it because of time, the pathophysiology. I won't talk about the long volume and stuff. We'll still find time. I love those long volume kind of things, but just that. I really have some important things to discuss over this one. So I won't talk about long volume now. So, all right. But I've mentioned pneumonia the other time, indirectly, how pneumonia can kick in. They are not taking in good bread. They are having what's it called now? Their secretion is being sticky. They are not able to clear the airway. Some of them might even be struggling with eating, drinking. They are not there. Before you know, they'll start getting dehydrated because somebody in pain. You need attention to do life. We need to be attentive to be able to do our life affairs. Somebody groaning in pain, things will start coming down. Before you know, they are dehydrated. Pneumonia and bacteria, they love those environments. They will start growing white blood cells, CRP, everything start going up. Lung contusion, we have explained. Associated injuries, we have mentioned them. Some of the other things we also need to be aware of because of time. For instance, now, if somebody has broken their first rib, for instance, physio stuff again. Physio stuff. Look at those neurovascular bundles that pass through those first ribs under your clavicle and those things. You might start thinking about brachial injuries. Think about injury to the subclavian arteries. Think about those things. These are now where's the first ribs? In my head, I would think, yeah, anything. So if I go to their bedside now, I want to check their upper limbs, range of motion. I want to check sensation. I want to check. There is reason for you to do that. Not random physio, like I used to say. Not random physio that I think every patient you need to be checking range of motion and strength for every patient. It's not in every patient. There should be rationale. We are not technicians. We are not programmed to be doing certain things. I am not supposed to be doing. I'm not programmed that every patient that comes to my hospital with a stroke, they need TENS machine, or every back patient, they need infrared. You are programmed. That's a technician. There should be reason for you. There should be good clinical reasoning for you why you are using that thing. So if I go to their bedside, they go first fracture. In my head, I'm thinking about precious injuries, vascular, blah, 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 all those things. I have good reason to do certain things in their upper limbs. This is clinical reasoning. If that makes sense. Flare ribs, flare chest. We have explained paradoxical movement and those things. Let's move forward. Again, this is the picture showing. The shocking in of the thoracic region, of the thorax during inspiration. Normally, your thorax needs to move upward and outward during inspiration. But what happens with flare chest is they start shocking in. Think about those things. And the opposite will now happen. Normally, during expiration, you want the thorax to come down. But what happens during expiration? they will get inflated. They will bounce back. Think about these things. All right. Associated injuries. Again, if somebody have got rib fracture, they might also be sternal fracture. They might have also broken their sternum. Think about that. And sternum, again, it could be displaced, it could be undisplaced. Think about that as well. So if somebody is coming with a maybe displaced sternal fracture, in my head, I'll be like, anything to the lungs, any puncture to the heart, any puncture to the. Think about those things. All right. These are just pictures showing those. If you look at this picture here, You can see the fracture of the sternum. If you look behind, what is this? If you look behind, you can see this fracture of this thoracic vertebra here as well. So think about those things. Pneumothorax. Ideally, I could have actually come up with some chest X-rays and show, but I just postponed that to some other part of it so that we won't move away from today's content. So show us pneumothorax, how to identify pneumothorax and all of those things, but we'll still discuss later in our later in the future. So we have discussed these things. And again, like I mentioned, refractor one, you are thinking about subclavian vessels or brachial plexus injuries. Think about these things with patient with refracture. All right, another thing now, evidence-based. Now, I've got a patient. Hello, are we still there, please? I've lost the connection.
Yes, sir, we are here.
So in terms of evidence-based, there is something we call stumble score. And I will encourage us when in our practice, when we come across patient with refracture, I will encourage us to complete stumble score. Stumble score is just to give us some kind of risk stratifications, just to know, oh, is this patient at high risk of complications, or is this patient at less risk of complication? What kind of treatment approach do I need to be doing with this patient? Even if they are not having complications, but they've got a very, very high chance that they can develop, that they can develop complication, but you can be doing some prophylactic treatment, just in case, if they might start heading up towards complication. No, we started, we started prophylactic treatment. So this stumble score is a good way, evidence-based wise, that they have been recommended to be doing with our patients. So now on these things, what do we find? You find things like, one sec. Sorry, let me just drag this down. So you find things like age. You find age on it. Of course, we can relate. Of course, the older your patient, the more chance that if they had the chest trauma, the more chance that they may develop complications. Great, of course, everyone can relate to that. Numbers of ribs, of course, the more the numbers of ribs that is involved, the more the pain, the more the struggle, the more chance of them coming up with complications. And again, the more the associated injuries, pneumothorax, this, what is it again? Sternal injury, heart puncture, this, the more chance that they may also develop complications. Now, pre-injury anticoagulations. Let me get physio again to talk about this. How is that related with somebody having complications? Anticoagulants, like before they have injury, before they have trauma to their chest, they've been on anticoagulant for a long period of time. How does that put them at high risk that they may have complications? How does that impact? How does it come in at something we need to be checking for patients that have chest trauma? How does it come in? Let me just clinical reasonings. Yeah, let me see. Yeah, thank you very much. PT Chidira, PT Fawzat. Risk of bleeding. I think indirectly the other time I've also mentioned that again. You might find patients, adults, or they may be on long-term warfarins, long-term abizabans, or different medications. Some of these medications, again, if they are on anticoagulant, they are at high risk of bleeding more than enough, internal bleedings. If you've got somebody like that, that also put them at risk that, this patient might have complications. All right, chronic lung conditions, how does that impact? Let me get the reasoning again. Let me get our reasoning again. Chronic lung conditions, you've got somebody with COPD, or they've got emphysema, or they've got chronic bronchitis, or they've got anything. It might even be heart issues. They've got heart failures or anything before they come in, or they are dealing naturally before their background is they are dealing with COPD. They are dealing with bronchostasis. They are dealing with emphysema. They are chronic smokers. They are this, they are that. Now they have trauma to their chest. how does that put them at risk of complication, at risk of deterioration? Can I get some reasoning, please? Can I get some reasoning? Yeah, how does that put them at risk of complications? Because sometimes it might not even be me doing this, completing this thing, even though I will encourage us to be doing this. It might be me looking at their caseload and paying attention to their past medical history. Oh, past medical history is chronic smoker, COPD. What does that tell you? How does that impact their chance of chest complication? All right, what do we think? Chronic lung condition, COPD. Okay, let's think about this. You've got a patient, COPD patient now. They now have flare chest. How do you think, what do you think will be in terms of complications, how do you think they may likely be presenting? Okay, let's check the chat box again. All right, thank you, Petit Ibrahim. Reduced lung compliance as a result of chronic lung condition. Perfect 100%. If somebody they've got restricted lung conditions, or they've got anything, pulmonary fibrosis, blah, 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 what will happen? Their compliance will be, their lungs the compliance is not there before they have the injury. Now they have chest injury. They now have pain in their chest. You now think the compliance will be okay? The compliance will be lesser than expected. And what does that mean to us as respiratory physio, as chest physio, as great physio? What does that mean to us? Poor lung volume, poor saturations, increased oxygen requirement, secretion retention. That is these things. Thank you very much. Thank you very, very much. Let me check again. Lovely physios here. Yeah. Go up. Yeah. Pity Messi. No, let me get. I think I'm. Let me come down maybe. Yeah, bronchiostasis. Yeah, Stella, bronchiostasis. Reduce mucociliary escalator. Perfect, 100%. I love that. Think about it. Somebody normally have a thick secretions, very thick secretion. They struggle normally to clear their airway. Now they now have chest trauma. Do you now think, now that they have chest trauma, they have pain in their chest, do you now think they will now find it easy to be able to clear their airway? No. What will happen? Their secretion, they will now start having, the chance is now there for them to now start retaining those secretions in their chest. This is what it means. Thank you very much, Pretty Stella. And again, because it might be because they are not eating now, they are not drinking, they are just, attention is just, they are just fixating on pain. They are fixating on pain, they are not drinking a lot of fluid as expected. What will happen? The activities of mucociliary escalator will start going down. The secretion will start getting dry. If you see this as physio, you are the best. What do you want to say to the medical team? Prescribe nerves, give them nerves. You might start with 0.9 regular nerves, saline nerves, give them saline nerves. If that is not, and again, for somebody with bronchostasis as their baseline, thick secretion, I might even jump the ladder and say, yeah, give them 7%. If what I'm saying is really, really very terrible, I can say give them 7%. I can even say, even some of them might even be on 7%, 6% before they come to before their trauma. I might say, okay, give them with carbon-16, mucolytic and this thing, give them with carbon-16. Let's make it more easy. So they need those secretions to be softened so that they can easily clear their airway. If it is very thick, they will find it difficult. Already, their cough strength is reduced because of they cannot take in deep breath, they are avoiding cough. So now the secretion is now thicker. It's like more pain, is my more trouble on top of what they've got initially. If that makes sense. All right, thank you, PT. Let me see again. That's PT Stella, PT Ibrahim, reduced lung volume, ABG, will highly be, yeah. If lung volume is reduced, atelectasis, lung volume is collapsed, yeah. The oxygen will be drained. They might be having type 1 respiratory failure. Great stuff. Atelectasis, good stuff. Yeah. Prolonged hospitalization, that is it. Of course, so you cannot discharge somebody that is not optimized. That's not optimized. Their oxygen, they are on 60% oxygen. You cannot discharge them home. They are on high amount of oxygen. You cannot send them home. We need to get them well before we discharge them from hospital. And what does that mean? Prolonged length of hospital stay. What does that mean again to us as people? That is why we need to do our job. That is why we need to when they are in the hospital. Because now, so that immediately they are met fit, they did them met fit to go home, we also discharge them. We also discharge them from our caseload as well, because we also know the risk of somebody staying too long in the hospital. What are the risks? Nosocomial infection. They might catch infection. They might catch chest infection. They might catch pneumonia. And again, you are also blocking that bed. You are blocking the bed for somebody. You are also blocking the bed for some other patient that might also be needing those beds. And again, think about it. This is our country. These things are not free. They are not free. The longer the length of the hospital stay, the longer the pressure on the family, the longer the finances. We should be helping our people. We are lovely people. We are a lovely set of human beings. We should. These are some of the, aside from catching infection, catching this, catching that. We also, how about the financial part of it? All right, these things are not free in our country. So we need to be thinking about these things. All right, so thank you very much, everyone. So if somebody have got background, chest concern, anything, chest, respiratory problem, this further put them at risk of complications, at risk of great complications. Oxygen saturation, again, you go to their bedside, you are also looking at their saturation. Are they on 40% FiO2? Are they on 60% FiO2? We have had discussion about oxygen in the past. If you are unsure of anything, go back to those things and watch. As acute physios, we are expected to know oxygen very, very well. We are expected to know oxygen. You should be able to undo oxygen, know the indication for oxygen. You can win. When I was discussing oxygen the other day, you can win oxygen. You can bolus oxygen. Yeah, you can even administer in emergency situation. This is the guideline. This is the standard anywhere in the world. But you want to start fighting these things. The question is, do you also have the knowledge of these things? Are we being taught in our various background in our schools? Are we being taught about these things? That is why I keep saying, until we separate some of these things, everything is not outpatient. How about the acute hospitals? How about the acute? Those patients on 20%, 20%, 30% oxygen, you can still mobilize them with oxygen. This is physical stuff. You can still mobilize them. Use your mobility to enhance their minute volume. Use your mobility to increase their tidal volume, to increase their functional residual capacity, to increase their endurance. Then start winning. Work with the nurses to win them off the oxygen. Again, this is sad to say, but I will say it. I have spoken with some doctors here, like Nigerian-born doctors. They have practiced for donkey years in Nigeria. If people share their experience about sometimes how they forcefully win patients off oxygen in our country, how, in our country, we don't discharge patients with oxygen. And how about patients that may need long-term oxygen? This is the problem. Some people might be forcefully, be weaned off those oxygen. And what happened to them in the long run? Death. Again, physiotherapy will also help in some other aspects to help progress, use mobility to increase functions, use mobility to increase, the oxygen, use mobility to enhance, to facilitate their chest, to be able to use, for the patient to be able to use their natural oxygen, to be able to use their, to be able to breathe in properly and, increase their oxygen usage of their body. We are not going in. I'm sorry to say this, sometimes in some facilities in our country, if a patient is even 0.5 oxygen, some physios will run away. Some physios will run away. 0.5, not even up to 1. Some physios will run away. What is this? What is this? Run away. They will just say, no physio, they are not oxygen, no physio, until they are off oxygen. What are you doing? What are you saying? So this is why we also need to improve our acute care hospital. This is not disrespect to what we are doing, not disrespect to the lovely job we are doing, but the reality needs to be said. The reality needs to be said. The reality needs to be said. All right, thank you very much. Thank you very much. So like I mentioned, Stumble Score is those tools we can also use. Look into the age of that patient, look at the numbers of risks that are involved, look at and if they are on previous anticoagulant, you can speak with the medical doctor if you are not sure about that anticoagulant part. You can speak to your patient, you can check their past medical history, their drug histories, talk to them. Look into their background. Is there any clue again that can give you that this patient are likely to be on long-term anticoagulant? For instance, when I was talking about cardiac surgery the other time, I was talking about heart replacement and what do you call valve replacement. Patient with valve replacement, mechanical valve replacement, they might be on long-term anticoagulant. This is the standard. Because metallic, your body is not meant to have a metal. Your body is now having a metal in you. So they will put them on long-term. And by the time I look at their card and say, even before I go to speak with the doctor, I will try my own clinical reasoning. Look at things I can see, look at things I can, anything I can pick up. Think about all these things. All right, thank you. Let's move forward because of time. Sorry, is it making sense or hello? Are we still there? Let me drag this up.
Yes, sir.
All right.
We are here.
All right. Thank you. Yeah. So now, in terms of, let's say now you've done that stumble score kind of things, you can also use this to predict the complication. Oh, it's 0 to 10, 13%. This disease, 31, 85%. So that you can know, oh, I need to be seeing this patient. I don't need to be seeing this patient. I need to be seeing this one. So let's think about those things. All right. Thank you very much. Let me see. Someone have written something. Yes, thank you, Peter Ruben. Thank you for that. All right. Yeah. So now, in terms of, you now want to put them like a kind of what do you call it now? Stratifications of about if you break those things down now, the score down is 0 to 10 now. The standard is the first 24 hours, physio needs to see them. If you and again keep them at least 3 days, 72 hours in your case. They need to be seen by physio. Like I said the other time, it is not when the pain are fully gone. When the pain, they are now admitted on maybe trauma and orthopedic ward because of the chest trauma they've had, or they are admitted in cardiothoracic ward. Now they are seriously in pain, so there is no physio that time. They cannot work. What are you saying? It is your responsibility to educate those doctors that now they are in pain. Great, optimize their pain. I cannot do anything for their pain. Give them pain medication. This thing. Start thinking about what you can do with them. It is not, you don't have to wait until that pain has gone. It might be too late. It might be too late. So you need to start seeing them within that first 24 hours. This is evidence here. All right. So now in terms of physio review, what are you checking? You are checking, if let's say their score is 0 to 10, low risk. So you are checking their chest, you are doing your assessment. In terms of treatment, you are optimizing their pain medication with medical team, PRN with the nursing staff, all those things. What is your goal? Your goal, like I used to say, your goal is getting them out of bed. Remember the concept. The concept is if they are sitting in the chair, it is far, far better than if they are lying in bed. If they can sit out, why are they in bed? Think about these things. Why are they in bed? If they can sit out, tell them, oh, Baba, Mama, you need to be sitting out in chair at least 2-3 hours. Do that in the morning. If it is afternoon, do that. If they can, why are they in bed? All right. Now, if they can't leave the bed, think about what you can do with them in bed. Get them upright. You know that upright position. Remember the concept. That sitting up in bed, that upright position in bed is better than lying flat, lying supine in bed. Think about that. And in terms of your this thing, what do you want to say? What now? Like I mentioned, they can't leave the bed. Now, get them upright in bed. Do some deep breathing with them in bed. Ask them to be doing that repeatedly, hourly. Now, you can give them towel or pillow or anything to split their chest. We all know all of these things. Give them those things to be splitting their chest. Now, people ask questions about incentive spirometer. Incentive spirometer, the evidence around it is really, really very poor. Let me say it clearly again. The evidence is really, really very poor. Compare with mobility. Compare with other treatment adjuncts that you can do with your patient. But again, it could also be something that may facilitate somebody, to be doing some of these things, or to get that visual feedback and everything. Yeah, we know. But your goal, if somebody can walk, your goal is getting them to walk. Your goal is not to leave them in bed and be blowing incentive spirometer in bed. That is a poor practice. If this thing makes sense. Now, because of time, the other one, 11 to 25, think about it again. 11 to 25 is like moderate risk. The chance is there again for them to have complications, for them to have cardiac arrest and die, for them to have sputum retention and have pneumochest infection and die. The risk is there for them again. What do you want to do? Comments, I will say, okay, now, I can think about my treatment adjuncts. When it comes to adjuncts now, I might think about those things we want again in our country, those IPPB, there is no contraindication, those copacetic, there is no contraindication. And I also think about just like the the minimal risk. Mobilize them, get them out, get them to sit. If you know with your mobility, how does mobility impact their chest? Let's discuss, first of all. Let's discuss. How does mobility impact their chest? You know, if they stand, if they are walking, their minute volume will increase. What is minute volume? Respiratory rate by your, what is the tidal volume will increase. If they are walking, naturally, when they are walking, their chest rise will improve more than when they are sitting. Now, and again, what happened to them? You are also, by the time they are walking, their respiratory rate will start going up. Their chest expansion will start getting higher. But again, in some patients, that might not be their case. They might not be able to walk. They might not be able to stand. Or their chest rise might really be very poor. I might start thinking about my respiratory adjunct to support them. But if you've got somebody with 26 plus, the chance is really there. I will say, evidence has shown that what you need to be doing with them in bed is commence prophylactic treatment. If you don't do those prophylactic treatment to that patient may die. They might catch chest infections. They might die of respiratory arrest. What are prophylactic treatment now? Give them positive pressure, something that can further inflate their chest, something that can requit their lung volume. If they've got atelectasis, if they've got chance to have atelectasis, even if they don't have atelectasis, something that can, what is it again? Something that can stimulate their cough, something that can promote that expiratory flow bias, all those things. I don't know. So commence those prophylactic treatment with them. Okay, I'll still come back to this. I'll still break down those our treatment plan later in the teaching. Let's just continue. Now, aside from checking their chest as a physio, you've also got responsibility to be looking at their range of motion in the upper limb. Somebody they've got trauma in the chest. Because of pain, there might be restrictions in the upper limb. If there is no contraindication, now somebody might also have maybe fracture of maybe fracture of big sternum or something. Sometimes they might say it's not very common, but something that is also possible. They might say sternal precaution, for instance. Keep the upper limb at the shoulder level at 90 degrees. Just stay with that and think about what you can do with them within that range, if that is making sense. So think about it. Think about clear the upper limb. Look at their notes. Have they not got any injury in the upper limb? Look at their notes. Clear that upper limb. If the upper limb is clear, you can start moving them. If there is nothing in their lower limb, mobilize them. Get them to sit out. Get them to do deep breathing. Get them to do those post-sleep breathing and everything. All those things. Get them to do all of those things. All right. So again, if you can also have somebody struggling with thick secretions and all of those things, you might find them on dry oxygen. You can find them on nasal cannula. You can find them on non-rebreathe. Think about swapping those things to humidified oxygen. If you are not confident to do that, talk to the medical team, talk to the nursing staff, give them humidified oxygen that will be humidified, because you know now they've got secretion in their chest. That dry oxygen will further you are giving them dry oxygen, that will further make their airway to be dry. That will not help them. Already, they might be having a poor cough because of the pain and everything and the avoidance and everything. Now they are now having secretion retention. Now you are now giving them dry oxygen again. What are you doing? So think about it. They might need humidified oxygen. They might need nebulizers to help them, PRN. You can give these people PRN. I don't know. Sometimes these are some of those things that need to be physio-led, because you are the one dealing with these things. You can say, sometimes here you might say, they are on BD. Maybe BD is what the doctor has prescribed. You can speak to the doctor. Why not QDS? Give them 4 times in a day. For that something, you have good clinical reasoning. You already know why you are saying those things. Because this will further help their secretion clearance and everything. You are the one dealing with secretion. You are the one that should be leading in those things. Even though you cannot prescribe them, but you can have those conversations for them to prescribe those things. Does that make sense? Now say, I will just move away from these things. I will send us the slide, look at the slide and everything. So there's another one here, refracture score. I won't go through this one. Just stay with that stumble score. Very direct something. You use that. Look at it. What scale are they? Their chance is high, their chance is low. What will I start to do with them? That's it. So in terms of management, general management now, General management, let's discuss. I'll go back to the previous slide. Now, how do you access this patient, first of all? Because we need to, first of all, identify our problem list to be able to know what we are treating. So now, if you really want to speak, you can open your mic. If you want to chat in the chat box, that is also welcome. How do we assess patient with rib fracture? Let's say now you are the physio in charge, you are the one leading us for the ward round, or you are the on-call physio or whatever now. So what assessment will you be doing with this patient at the bedside? You have gone to their bedside now. What assessment will you be doing with them? I will even appreciate speaking than typing, because it might be much, might be really too like. But if you still want to type, put it in the chat box. So what assessment are we supposed to be doing with this patient? Anyone helping us? How do we assess them? Somebody have got flare chest, or they've got refractor 1 to 2 or 3 to 5, whatever. So now, how do we assess them? How do we assess them? Hope I'm not speaking to myself now. Hello, are we still there? Hello? Hello?
Yes, hello. Well, with you, sir.
We can hear you. I can see you.
Oh, okay, all right, thank you. So how do we assess this patient with rib fracture? What kind of assessments? How do we assess them? I've gone to their bedside now. What am I checking? I've read their medical notes, or you can still talk us through what you are picking in their medical notes, everything, formulating your clinical reasoning before you go to their bedside. Of course, I will normally encourage people, before you go to patient bedside, you have read their notes, have your plan. I know by the time you get to their bedside, things might change, but already have an idea of what you are likely to be doing with them at the bedside. Now, you are going through their medical note. What are you paying attention to in their medical notes? And why are you checking those things? And when you get to their bedside, what are you checking with them? Can we have physios, lovely physios, brilliant physios, excellent physios? Please talk. Let's learn. Talk. So how do we assess them? How do we assess them? Yeah, who is leading us? Who is that? Yeah, thank you, PT Fauzat. She's rating, yeah, oxygen saturation level, yeah, we have to check that. Yeah, PT Grace from medical chart, thank you. Mechanisms of injury, 100%. We need to pay attention to their mechanism of the injury. What kind of injury? Is it road traffic collision? Is it road traffic accident? Is it blah, blah, blah? Is it direct trauma? Is it blow? Is it spot injury? Pay attention to those things. Even from their injury, you can even link that up to their level of frailty or something. You are looking at where they are coming from. Think about those things. Now, investigation done. Thank you very much, PT Grace. What investigation have they done? These are what you are checking. Because somebody with chest trauma, they might have puncture to the heart, puncture to the lungs. They might have pneumothorax, they might have fracture every other place in their body. They might have spinal fracture. You are checking every investigation in total. You don't just jump into their bedside and start acting like a technician. No, you are checking everything. Oh, spinal fracture. Have they got what's it called now? MRI. They've done X-ray, blah blah blah, X-ray chest or something. They've done X-ray for the upper limb, X-ray for the this thing. Have they been seen by TNO, by the trauma team? Have they been seen by the orthopedic team? What did they say? These are what you are checking. What did the orthopedic? What have they said to the upper limb? Are they for surgery? Are they for conservative management? If they've got anything in the spine, spinal team, neuro team, this is how you think in the acute hospital. They got injury to their spine, to their spinal cord or something. What have the neuro team? What have they said? Are they for conservative management? Do they need, or to the spinal, because of spinal injury, they have thoracic injury? Are they for braces? Are they for conservative management? Do they need TLSO? Do they need some? Think about those things. Clear those different injuries they've had. Any investigation they've done, have a look about it. What does the radiographer, what do they report? If you are very good in reading investigation, have a look at it. Read yourself. Look at their report as well. Look at what doctor, the team. Again, another thing we need to tell ourselves is, for instance, somebody have got spinal injury now. I might be thinking, oh, what team will be leading that? It might be team, like we call in Nigeria, it might be neuro team. So you need to be thinking about, yeah, I should be checking for this thing. I should be checking for this thing. Oh, if somebody have got, let's say they now have pneumothorax or something, what team will be needing? You don't expect orthopedic team to be telling you to be leading care for somebody that have got pneumothorax. It does not make sense. You need, I don't know how it works in Nigeria, but generally here it might be cardiothoracic team. It might be this. It might think about that. Think about what is the plan. Are they for chest drains? Are they putting chest drains? Are they for conservative management? Is there any precautions? You are clearing those things one after the other. ABGs, if they are in tanky PT grace, thank you. And now, what amount of oxygen? You are looking at the nursing note as well. You are looking at their hubs they've been doing on the ward. 20% their hubs is this, the oxygen level is this, their respiratory rate is this. At temperature, you are checking those things, you are checking everything. Now you see that somebody is on 40, 60, high amount of oxygen. You might be thinking, have they done ABG? Go and check ABG. What is the rating? This is how we think. Oh, thank you very much, PT Grace. I'm still using your stuff. The bloods they've done, the blood. Somebody that have got road traffic accident, they might have lost blood at the scene of that accident. Have you checked their HB? No, they are in the hospital. Their heart rate might be going up and these things. Have you checked their potassium level? Have you checked their different things? Have you checked their INR? Have you checked their platelet level? Think about these things. Think about all these things. Now, they have been admitted for a while now. Maybe they have been previously been seen by the other colleague. Now you are the one coming to be seeing them now. Okay, they have been admitted for a while now. They came in with chest issues and this thing, chest pain and this thing. Have you checked their CRP, their infection marker? Have you checked their CRP? Have you checked their white blood cell? Don't just dump in without checking all these things. You will make poor decision for your patient. You will never understand anything. You will just go there and be doing random stuff that everybody will be doing. Every technician, we are not technicians, we are good physios. We are not technicians, we are well-trained people. You go there, now you use all these things to formulate, oh, I'm checking, I'm seeing CRP, white blood cell deranged, everything going wayward. They are now on 40% oxygen. I'm start thinking in my head, oh, chest infection, pneumonia, this. I start connecting these things together. Oh, they've done chest X-ray. Chest X-ray is now showing atelectasis consolidation. Oh, no, I will start connecting all these things together. Vital signs, their hubs. Thank you, PT Grace. PT Grace, thank you very much. I appreciate that. PT Faster has also written, yeah, this year, yeah. Thank you for their level, what's it called now? For their alertness level. Checking for all of those things. Checking is really, really very important. Some people, they might have a very, very severe injury. They might not even be alert. They might even be unconscious. You're also paying attention to those things in their note. Yeah. Rate of exertions, all those things are important. Blood, chest drains. If they have chest drains. Now, last time we couldn't talk about thoracic part of it. Ideally, I was supposed to talk about, guide us about how we read all these chest drains, swinging, bubbling, all those things, suction, drains on suction. But the slide is, I've already prepared the slide. Maybe later on, if you have the time, I can just show us how you look into those things, how what you need to know from physio perspective and how they are linked to our practice. Chest drain is important. You might go to their bedside. You might find people on chest drains. Have you checked? Is there drain on suction? Is it active drains? Is it passive drains? What's the target in terms of drainage from the nursing staff? All right, breathing patterns. Now you are at their bedside now. People are coming up with bedside stuff now. You are at their bedside. What are you checking? You are checking their breathing, their breathing pattern. Is it paradoxical? Is it normal breathing? Do they have that full thoracic expansion? Their full thoracic expansion, or is it reduced? Is it symmetrical? These are what you are checking. Okay, before you come to their bedside, you are checking, you have checked their X-ray, their scan and everything. Great job. Now, PT Fausat, thank you. Before you go again, in the medical note, you are paying attention to mechanism. When did they have the injury? How long did they have it? What led to the injury? Their complications, everything. Past medical issues. Because you know, past medical insurance is also very important. You are taking those things before you go to their bedside. Oh, what is their normal mobility baseline? Are they normally are they young? Are they active? Are they very independent? They mobilize with stick, with frame? Check those things before you go in. Medical team will also have an iota of those things in their note. Even your mobility or everything, they will have it. Now at their bedside, thank you, Pretty Honey. Yeah, you are checking their pain. Be a good physio. You can never treat somebody well if somebody is groaning in pain. Be compassionate. Have you asked them, do your pain assessment? Where is the pain? Will you describe? Is it stabbing? Is it this? Those are pain assessment. Ask them to rate the pain. Oh, how bad is the pain on a scale of 1 to 10? All those kind of things. Get to those things. Then show compassion to them. Don't shout on them. I keep saying it. It's very, very, very wrong of anyone. Your patient is going in pain and you are shouting on them. It's really very wrong. These are bad practice that we need, and we need MRTB to be investigating people that are doing those things. People nurses on the ward. Don't they shout on people? Hey, JB, we have given you those pain medications. Well, you have to bear some pain. No, this is bad. Doing those things, what those things does to patients is it further make those pain experience, that painful sensation, it further make it worse. What you are doing is you are also stimulating their what do you call it now? Their sympathetic nerve to keep firing and make those pain experience more worse for them. Before you know, some patients might even be anxious. That pain experience will get worse. Let's think about these things. So we need those good, compassion, empathetic approach. Thank you very much, Pitiani. I love that. Now, target vital signs. Thank you, Piti Stella. You might find people that are really, really, at the moment, they are really, really very poorly in bed. You might find a lot of, maybe, the medical team might say the target saturation might be greater than 95. They might say if they are coming from a poor respiratory background like COPD, chronic condition, neuromuscular disease, GBS syndrome of the gut, what's it called? Chest deformity, kyphoscoliotic spine, or anything deformity. They might say maybe keep their target SAT to be 88 to 92, something like that. You might find different things. Pay attention to those things. And again, just like for SAT now, for instance, I cannot say my patient is desaturating if I don't even know what target are we aiming at. We have to know. We have to know those things. So it's really important. Thank you very much. I appreciate those things. So I'll just move to the next slide now. So now to make it more, let me drag this one down. To make it more these things, of course, we can all agree that what we are doing is, what you are going to do with them is, you want to do respiratory assessment. You want to do pain assessment, like their injury assessment, the mechanism, everything, pain assessment, even the pain. If I'm at their bedside, even the pain. What I normally do and what I like people to be doing, what I will encourage us to be doing is, don't just do, how bad is the pain? 1 to 10, 8, 7, 10. Because the presentation of pain, when they are at rest, in fact, the way people normally report it is when they are static. Static is maybe they are at rest now. They are not coughing. They are not taking in deep breath. They are just normal breathing. They are just normal thing like everybody. Rate their pain at that level. If they are coughing, if they need to cough, or if maybe at a point you ask them to do deep breathing in bed or something, or they are sneezing, ask them dynamic pain. Ask them about dynamic pain. How bad is that pain? What I'm saying is, do the pain and ask them, what is your scale? Like what is their pain rating when they are resting, when they are not coughing, when they are not sneezing? If they need to cough, what is the pain? Because you know as physio in your head that this pain pattern, this pain what is it now? This pain intensity will be quite different. Ask them those things. Again, that might also be a guide for you. If you need to ask them to cough, that might also guide you that, oh yeah, somebody complaining of this, that yeah, I don't want to cough. It's really terrible. They are very anxious about that. Then you can start, okay, don't let us do coffee. Let's start do offering or something like that. Do all these things. Medication, you have checked their medication, you have checked blood, you have checked their post-op, know if they've done surgery or anything. Check those things, their blood, everything, imaging, blood, caution, red flag. You might find some red flag. Someone that have come with maybe fracture of the femur or tibia or something, they might say, non-weight bearing on this. Stay with those things, clear those things. Or somebody that have got pneumothorax. In terms of my selection of a treatment, if I need to do anything positive pressure, for instance, now, I might also want to do maybe weighing risk and benefits. Put it in the context of my patient. Do I really need to do this thing? Or why do I really need to do this thing? If they've got chest drain, again, before I do those things, don't worry about positive pressure for now, but I'll still explain later on. If they need to, I need to do positive pressure. I might also look at the drains. Are they swinging and bubbling and those things before I start? So some critical decision in some clinical areas like ITU, for instance, or like general ITU or cardiothoracic ITU, or even pediatrics ADU, for instance, you might really need to do those critical decisions. So you might really need to do, for instance, if somebody have gone, maybe they've got hemothorax with whatever they've got now, or they've got pleural effusion with whatever they've got, or they've got sternal fracture. I need to weigh in some of my treatment approach. I need to do risk versus benefit. If I do this thing with them, what will happen? If I don't do this thing with them, what will happen? I need to read medical notes and put those things into my own physiopath. It is not doctor that will dictate for me. Even though I will still go to have this discussion with the doctor. If somebody has got sternal fracture now, for instance, or somebody has got pleural effusion, they don't have chest drains. They have said conservative management. I know that if I want to use positive pressure with them, for instance, now, I know that the chance is there that that ear can link into their pleural cavity. I know that for sure. I know that is a big red flag for me. I know as physio. But I know at the same time that if they really need that positive pressure, if I don't do it, they might also end up respiratory failure. I might need to do weight risk versus benefit. I might need to go have that discussion with that medical doctor that, look, this is what I've got. I am limited in terms of treatment. This is what I need to do. Are you guys happy? Have you got an escalation plan? If that, well, I'm trying to help my patient, but if things go worse, have you got that escalation plan on ground for them? They will say yes, they might say no. Have those conversations with them, but these are things we need to understand. Anyway, you go to their bedside again. What are you checking their bedside? To make this thing structured, you can go with A to E assessment. I want to assess their respiratory stuff now. I may want to do, I don't know why I've not put this thing here. You may want to do A to E assessment. A is their airway. Let me just go through this thing with you. Are we still there? Let me just quickly double check. Are we still there, please? Can you confirm, please? Are we still there?
Yes, we're here.
Yeah. Can I get a few more people? Thank you very much. Yeah.
Yes, we are here, sir.
Yes, sir, we are here.
All right. Thank you very much. Perfect. So we can do A to E assessment. A to E assessment. A is their airway. B is breathing. C is circulation. D is, what is D again? Disability. Disability is their neuro. They are checking their neuro stuff. E is everything else. Now, A is their airway. What are you checking in their airway? You are checking if their airway is patent. How do you know? I'm speaking to you now. My airway is patent. I'm speaking clearly. All right. If you are going, somebody mentioned grunting sign the other time as one of the, what is it now? If somebody is on patient, they are on respiratory grace, somebody might be grunting. Or if you go to someone's bedside, they are just modeling everything or something. Or you can even go to the patient bedside and you can hear audible secretions. You can hear it. You can hear that something is at the back of their throat. Secretion is lodging there. They are there at the back of. You can hear it. You can document. Hey, if they've got, and again, you can also go to patient bedside. Somebody might be on tracheostomy. Somebody might have ETT, depending on where you are seeing them, either in ITU or somewhere here. You document. Hey, is tracheostomy, this thing, put the size of the trachea. We have had discussion on trachea, put the size. I made a video again. If the size of tracheostomy, size C, size, this thing, inner tube, ventilator, if it is trachea. But if it is normal, you like normal, no tube, nothing, no plastic, nothing. Just say they have their own airway. That's great. Then their airway, is it patent? Is it patent? How do you deem it patent or non-patent? If you even without auscultating or anything, you even you yourself can know. Put it there. How about B? B is the breathing. What are everything breathing now? Everything respiratory is their breathing. What are you checking? Are they on oxygen? If they are on oxygen, put it there. What type of oxygen device? Are they on? Is it venturi? Is it nasal cannula? Is it humidified oxygen? Is it non-rebreathed? Is it anything oxygen? Is it humidified oxygen? Is it aqua pack? Anything oxygen, put it there. Go back to those things. Those things we have had in the past. Put those things there. They are on 2 liter of nasal cannula. They are on 2 liter via nasal cannula. What is their SpO2? Oh, 92%. You can even open the bracket and put target sat there. Oh, their target sat, they are having 92% nasal cannula. They are saturated, their sat is 92, but we are aiming at greater than 95. They are on scale 1. Or we are aiming at 88 to 92. We are on scale 2. Something like that. Put those things there. Aside from their oxygen level, and if somebody is on, you can also go there again and find somebody on NIV. They might be on BiPAP. Put it there. Oh, and they are on NIV, their pressure support. I will still discuss those things. Don't be worried about that for now. Put those things there again. I'm just making us be aware. Put those things down. Or pressure support is this, or peak inspiratory pressure is this, this thing is this, their PEEP is this, or put those things there. Put those things there. Then aside from those things again, what else again? You have the numbers of oxygen, the amount of oxygen they are on, their saturation is there. Again, look at their chest. Look at their chest. What can you visibly see? What can you visibly see in their chest? Is there equal rise in chest? Is it full expansion? You don't have the, I don't know. Sometimes people will say, hey, let's say you do tape measure. Why are you doing tape measuring? What matters to you? Now, if you do tape measuring in the hand, yeah, I know it's something we can, maybe the one you track it, is it improving? Is it not? But you can sometimes you can objectively look at something and say, I know it could be subjective. I know tape measuring too. We also help in tracking those things, but you don't actually necessarily have to do tape measuring. There's no time for those things. Don't look at it. Oh, look at it and say, oh yeah, it is equal, it is falling in. And again, it might be difficult for you to palpate their chest and say, yeah, let me put my arm in, is equal. Somebody that is, they'll be guiding, muscle guiding. If they want it to touch, it will be very tender, it's very sore. Chest fracture is really very sore. So you may not need to actually palpate. But again, if they are ventilated sedated, you must still palpate and see again. And again, if some people can still tolerate it, you can still palpate and just place your hand, see if there is equal rise in thoracic expansions. And again, while you are also palpating, you are also feeling for tactile parameters. You don't have to just feel. Is there any palpable sec when you are doing those things? Put those things will come under your breathing. Well, you don't necessarily have to say, oh, yeah, let me do tape measurement. It has to be from intercostal region to clinical to from there to this. Why are you doing those things? Why are you cramming anatomical landmark? For what? For what? You don't need to cram that. What matters is that your physio. You don't need to cram any anatomical landmark and start taping anything. It's not necessary. Now, after you've done those things, put your auscultation, put your stats, auscultate them. What are you checking? Oh, yeah, there is. Again, what are you listening to? You are listening to their breath sound. Is there breath sound throughout their lung field? Can you hear any added sound? Those two things are very important to you. That is what is really very important to you as physio. Is it quiet anywhere in the lungs? Is it quiet anywhere in their lungs? And added sound, oh, crepitors, oh, expiratory creps, inspiratory creps, or they are whistling throughout. This is what matters to you as physio. Not the testes in the coastal region, you do why are you cramming these things? And in the end, you will see patient will be able to do it. Just palpate normally. This point, go there, the lower lobe at this side, you are fine. Great. That's simple. That's all. You have done your breathing. Again, under your breathing again, what should come in? You can do your they've done chest X-ray for them. What do you find in the chest X-ray? Put it there. Put the chest X-ray or consolidation at this side, whiteness, harshness, and you again on the chest X-ray. I don't necessarily have to be making diagnosis on the chest X-ray and be saying, yeah, this is electricis and clinical and this. No, just look at it and say there is lung collapse and this and this and your own. What really matters is not that is your treatment. You are not making medical diagnosis. After the X-ray, if they've done ABGs, ABG can also come under your breathing. Put the ABG value when you are writing your note. And what do you see? Oh, this is likely to be respiratory disease, blah, 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 acidosis, CO2 is running up. Especially as physio, you are paying attention to 3 things on that ABG. You are paying attention to the oxygen, you are paying attention to the pH, you are paying attention to the CO2. This is what you are paying attention. Is the CO2 going higher than expected? Is the pH dropping than expected? Yeah? pH dropping than expected. CO2 going higher than expected. Oxygen dropping than, what is that? Type 2. I'm start thinking in my head, what is going on? This is what you are checking. So let me summarize. A is you are looking at the airway. B, you are looking at the breathing. You are checking their oxygen, what amount of oxygen, what is their saturation. You are looking at their chest, thoracic expansion. You are auscultating them. And again, in that breathing again, you can still ask them to cough. You say cough to command. You can just maybe give them towel or pillow or anything to spring that, because you know cough is important. You can still ask them to cough. Some people will have, and you have to grade your cough. I know it's subjective. You have to grade that cough. Is it strong cough? Is it weak cough? Is it moderate cough? Put it in your note based on what you can see. Based on what you can see and hear. Put it in your note. It's important. And again, if they clear that cough, is it strong? Is it weak? Is it moderate? If they clear anything, put it in your note. Oh, what did they clear? If it's productive, put it there. What did they clear? Loose, thick, secretion, moderate. Put those things. What is the color? Pay attention to those things. You put those things in your notes. These are your objective marker again. These are your outcome measure again. Your cough is outcome measure. Your SPT is outcome measure. Your auscultation is outcome measure. Your palpation is outcome measure. You already doing your stuff. The C is anything C, circulations. Circulation, your heart rate, your respiratory, respiratory rate will also come under breathing. Your heart rate, your blood pressure, your blood can also come under your C. Under your C, when you are making your documentation, under your C. Well, what is that? Your CRP, pay attention to CRP, to white blood cell, pay attention to platelet, pay attention to INR, pay attention to AHP if you need to mobilize them. Your D is your neuro. If they are on the ward, if they are ward patient, just do ACPU. Are they alert? Are they confused? Are they in pain? Are they unresponsive? Of course, unresponsive should not even be on the ward. If you find a patient that is unresponsive on the ward, put the call bed. They need medical attention immediately. Unresponsive patients should be in the ITU. They are being ITU, of course. If patient is sedated and intubated, they may be unresponsive. They should be in the ITU, not on the ward. This is your C. Your D, your D, after explaining the D is disability, which is your neuro. Your E is everything else you can see. Are they attached to anything? Do they have urinary catheter? Do they have this? Do they have that? Document those things and check. You have done respiratory assessment. That's cool, lovely stuff. Then again, upper limbs, like we mentioned, you have to be checking the upper limbs. There is no contraindication for them to move their hand. Check sensation, check range of motion. You have reasoning to be doing those things. And again, what are you thinking about now? If they are able to think about, ask them to take, I will show compassion to their pain. If they need pain medication, I can go speak to the nursing staff, give them pain medication, PRN, pain medication. I can come back later. If they are in serious pain, maybe 20 minutes, 30 minutes after an hour, come back to see them. All right, get them to do gentle thoracic expansion in bed, inspiratory hold in bed, but top of your skills, get them out of bed if they are able. Yeah, this is how you are doing. And again, for that pain, let me say this thing again. As physio, we need to be aware of pain algorithm in our hospital, where you work. Speak with the medical. You need to be aware. Because for this patient group, what I do normally, I will check their pain, their drug cardex, their drug chart. I will look at it and say, oh, why are they? Oh, they have had this morphine in the morning, they have had their own PRN, this and that. Because I know the pain algorithm of my hospital. I don't have to cram it in my head. It's already in the computer. If I'm not sure, I'll just go and look at, oh, they have had this one. Okay, if that pain is not enough, they can go on to the next step, onto the next ladder. I can call pain team and say, oh, my patient is in pain. They are not following instructions. They are not able to take in the bed. Are you guys happy to come and review for other pain concern or anything? They will come down, they will review. But they may ask you, okay, what pain are they on? Maybe you are speaking to maybe someone else. Now, another colleague that have not met them before. They will ask you certain questions. You don't want to look like a fool. They will ask you some, oh, what pain medication are they? Do you know? They will ask you those things. Know those things and know those algorithms where patient can be, because these things are also linked to physios. All right, let's continue. So that's how you can do your assessment. So these are just, in terms of treatment, again, like I mentioned, mobility is a tough love. If you have seen patients with trauma, chest trauma, it's really a tough love. But it's a great thing to do with them, but it's really, really very tough. If they are able. And how do you know if patient is ready? to be mobilized again. That's another thing. Of course, you'll be led by their presentations. You'll be led by your bedside assessment with them in terms of their OBS. Say, for instance, patient heart rate is like 130, 140. Do you want to mobilize that? That's too much. You can't do that. Or their respiratory rate is just off. It's just like 30 something. They are really, really very, they are really, really working hard. They are working hard to breathe. Their accessory muscle is really, really very, they are using those accessory muscles and their respiratory is really very high. You can't work them. Think about what you can do with them, get them upright. And usually, like somebody mentioned the other time, you find them slump in bed, get them upright in bed, reposition them in bed. Even that positioning again could really be a tough one for you. Think about who do you need to call to help you. You are not manual labor. Don't be pulling and pulling this thing on bed. Get people, get nurse on the ward, get your colleague to come down to assist you, get that your junior colleague or student to assist you, to get them upright in bed. And ask them, encourage them, speak to them in a calm and lovely manner. All those things. All right, chest physios, like I mentioned, we can do our stuff with them. So this is for treatment escalation. I won't spend time on this because we have another session that talks about positive pressure and all of those things. But we can do cover sleeve, we can do belt. This one is going into, it's not, this place now is really going into extinction, but there is also options of what's it called now, IPBB on this cough assist machine as well, NIV, what's it called now, on this MIE as well. So this is NIVs. Again, there was a question I asked the other time that if you now find a patient, their ABG is deranged, their ABG is off, or they are really working hard, or a patient that is now on type 2 respiratory failure when they do their ABG, or they are really working hard, they are working hard. They are really working hard. So what can you do? What conversation can you have with the doctor to offload their breathing? I think I had that question the other time. You can try them on NIV. You might pop them on what's it called now? You can pop them on BiPAP, for instance. BiPAP can support their breathing, can offload their breathing, can support their breathing. BiPAP can support their inspiration, expiration, their CO2 management. If they are on type 2 respiratory failure, BiPAP can do that for you. If the oxygen is the problem at the moment, if the oxygen is their problem, what's it called? CPAP can also support them, can provide oxygenator, can offload that so that they can relax, their chest can relax. Those the accessory muscles that have kicked in, they can relax. You just can start patient on these things where here, because of competency and all of those things that people have had, you can start them on it. Speak with the doctor, start it at their bedside. Start it at their bedside. Pressure post, start everything and pop your patient on it. But yeah, if we've not got that competency, we are not allowed because of hospital governance or wherever or whatever, speak with the doctor. Oh, I think the patient will be needing this. Advocate for your patient because you know as physio, everyone. And again, the doctor, consultant, or whatever might not even be on the ward. It might just be you and that patient. It might just be you and that patient, and that patient is really working hard. Even the nurse on the ward might not even have that skills to recognize that this patient is deteriorating. It might be you that will make the difference for that patient. You don't even necessarily have to do anything. It might just be you just speak and say, please, can I have the contact of the consultant, please? I would really need to speak with them. It might just be you speaking on phone with these people and say, oh, I think I think this patient needs to be reviewed. I think they are really working hard. I think they may benefit. This is the problem again. Sometimes when we speak again, I think communication again is also another issue. We tend to be, what is the English now? We tend to be very too direct. Sometimes you know what you are saying. You have your clinical reasoning. You have that great clinical reasoning. But sometimes make it look like possibility because you know the decision is not left to you. You are not the one to make the decision. If that is the case where you are, but make it look like a possibility. Give them that chance to make their debate. Spell out why you are saying those things as well. Oh, I think this patient might benefit from NIV because I think at the bedside they are really working hard. All their accessory muscles are really kicking. Their ABGs is deranged. You have taught them through your assessment at the bedside. You have taught them do objective markers. They have done ABG. OBG is showing this, and this patient is really working now. And now they're even getting very, really, very, very drowsy. And again, when I spoke with the nurses before I went to their bedside, they mentioned to me that previously they were complaining of headaches and stuff. Oh, you you have already provided enough evidence for that patient to be needing NIV. And again, your communication was really excellent. You are not making it, hey, come down to the ward, get them an NIV. No, we are egocentric, we are too, no. But again, you are giving them that doubt, and you are advocating well for your patient. And you are document, I have done this, I spoke with this, get their name on phone, put those things in your notes. They should enter your notes. Ideally, our notes are, what is it now? They are legal documents. Those things should go into our notes. All right, so I won't spend too much of time on this, but just be aware, patient can be on NIV, they can deteriorate. NIV can help to offload their breathing, can help to offload their breathing, to support their breathing, to split their airway open. Tipper, it's going to split their airway open. It's going to improve their oxygenation and all of those things. All right. This again, another option, not very common, but you can also find patients with rib fixation as well that have gone surgeries for their ribs and all of those things. Yeah, can find some patients like, yeah. Another thing I really want us to discuss. So let me quickly read the chat box first to see what people have written there. Okay, great stuff. Yeah, guys, if you look at this again, what are our thoughts about the use of, what do you call this thing again? The use of corset or the use of binder, thoracic binder in a patient that have got acute chest trauma. What are our thoughts? If you want to speak, open your mic. If you want to put the response in the chat box, please do so. So what do we think? What do we think?
The breathing will be compromised.
Sorry, ma.
The breathing will be compromised.
Yeah. Okay, great stuff. Thank you very much for that. So our PT mentioned that the use of thoracic binder or corset or whatever you want to call it, she mentioned that the breathing will be compromised. Do we agree with that? What do we think?
Yes, and reduce the chest expansion.
And reduce chest expansion, 100%. This is not evidence-based. Unfortunately, we still have people doing this as well. This is not evidence-based. As physio, we can clinically reason that, oh, I want that nice and lovely thoracic expansion. I want their chest to be moving nice and moving up, and I just want their chest to be moving nicely. Now you are now providing something to further compromise the thoracic expansion. What are we doing? Before you know, oh my God, you are now facilitating that secondary complication. You are now facilitating that chest deterioration. Let me see what other PTs have written. Let me see what other PTs have written. Yeah, let me see. Yeah, great. Everyone is in agreement with that. Great. So this practice needs to be stopped. For a patient with rib fracture, don't even think about corset or whatever things you want to call it, because now we can unanimously agree that this is not evidence-based. And again, these things will reduce patient. It's something somebody can reason now. This thing will reduce their thoracic expansion. We want that thoracic expansion. We want that breath. And for you to be able to take deep breath, remember our pump handle the other time. You need that pump to come up. So if you are now restricting the pump, how will the lungs get those air? This is secondary complication. Secondary complication will set in. So this is not evidence-based. That practice needs to be stopped. All right. Again, how about this? Physios. How about the use of KT, kinesiotaping? We find people have come with this thing, the physio will go to the bedside, we start taping them up and down. What do we think about this one as well? What are our thoughts? What are our thoughts about that? All right, physio, what do we think about KT as well? What do we think? What are our thoughts? Because this is, of course, these are physio. Sorry. So yeah, what do we think about that? What do we think about that as well? KT taping, they've got 3-4 ribs now. We now tape everywhere. can tape nicely. These things are really very beautiful, honestly. So, well, what do we
Yes,
think about
some
it?
people use it. Yeah, sorry. Some people use it and they say it's effective, but personally, I don't go for kinesiotherapy.
Okay. Thank you very much. Yeah, great. Let's hear from other PT. So what do we think? What do we think? So for patients with acute refracture, they are in the hospital, they came in with refracture, flat chest. So what do we think? What do we think? What do we think? Let's share our thoughts. Let's share our thoughts. What do we think? Physios, we are not. What do we think? All right, let me read. Let me check the chat box. Somebody have popped in something. Okay, this one. Yeah, it is. Yeah, this is PT Chill. I don't know. PT. I'm sorry for the. It restricts deep breathing. Yeah. That's another angle. That's another perspective again. Thank you for adding that. Yeah. Thank you for adding that. Can we get a few more physios to speak on that? The use of KT for patients with acute refracture. Remember, what we want is that lovely chest thoracic excursion, that lovely chest expansion. So personally, I would say the evidence around it again is really very poor, because this can also restrict the thoracic excursion. It can also restrict the thoracic movement. So leave them, get them to do your deep breathing, get them to do anything that can facilitate their thoracic excursion, that can improve their collateral ventilation, that can improve their their FRC, their tidal volume. This is what we want to encourage patients to do. This is not also evidence-based. In this acute phase, it is also not evidence-based. We know it's really very beautiful, but it's not evidence-based. I know, yeah, again, in terms of pain management, it also had some tactile this thing to the pain management and the book. One thing first, weigh the two options. Pain, yeah, tactile stimulation equipped with pain a bit. Yeah, which is nice, which is lovely stuff. We want their pain. We know chest pain could really be really very sore, but look at on the other side of it. On the other side, if you are not getting that nice thoracic excursion, complications, which is a way higher. That complication that risk is way higher than pain management that these things was putting in the first place. If that makes sense. All right. So I generally don't encourage this. I don't encourage this one as well. So so now the other part of it, traumatic abdominal injuries, anything just like the chest again can also cause trauma to the abdomen because of time. There can be issue with liver, splenic lacerations, and you can also find patients with refracture with maybe trauma to the abdomen. They might say they have an emergency, they have emergency laparotomy, emergency laparoscopy surgeries or something. It's still the same thing with, we've had discussion about abdominal surgery. It's still the same thing, the way you will normally treat them, the way you will normally treat those people with maybe they have elective laparoscopy procedure or something. Still the same thing, yeah, nothing changes. All right. But the only thing you need to just be aware of here, because of time, is for that splenic injuries. Sometimes they might say some people need to be on bed rest. They might say some people need to be nailed by mouth for some period of time or something. Please, if they've not written that for splenic injury, clarify with the medical team first before you do anything with your patient, before you get them out. If you are thinking of mobility or anything, clarify with it. What is the line? Is it conservative? Is it whatever? Are they on any bed rest or anything? Clarify with them before you do your stuff with your patient. I'll go straight to the case study because of that. I like us to do maybe two. I think I'll pop in like a lot of them here, but we can just take two and we close the meeting. First one, case study. You've got 62-year-old man. They've got history of bronchiostasis. They're admitted to your hospital. They've had 3 to 5 refracture. They are on 3 liters of oxygen. They are unable to clear secretions. They are on severe pain. They are slumped in bed. Describe your pain. Describe your management. What are your management plans? 62-year-old man. They've got histories, background of bronchiostasis. They are in the hospital, 3 to 5th degree fracture, 3 liters on oxygen via nasal cannula. They are struggling to clear secretions. They are in pain. They are slumped in bed. What are your management? Please, physios, I really want us to talk about this. We can just take 2. I think I've got a lot of them here, but we can just take 1 or 2 and we'll leave. So who is helping us with this patient? So the way I want us to talk about this thing is, you can talk us through some assessment. You can talk us through what to be expecting. You can talk us through why this patient is having these difficulties. Just talk, just anything you can pick up from this patient situation now. Just talk us through it. So what do we think? They are 62. They have bronchostasis. They are on 3 liters of O2. They have 3 to 5th degree fracture. They are slumped in bed. They are in pain. They can't clear secretions. How do we help them? How do we help them? Hello, time is gone. We are doing overtime now, but let's quickly take some few case studies, because case study is in fact, maybe later in the future, we will just make some of these things case study. We just maybe orthopedic, we just take case study. And what's it called? Cardiothoracic, we do case study. General IT, we do case study. Neuro, we do case study. We can just do case study. Because case study is one of the best way to learn some of these things. To have that clinical reasoning. So let's take 1 or 2 and we leave. Hello. Who is helping us? Hello? Time is gone. Who is, oh, am I talking to myself? Are we still here, please? Hello?
We are here, sir.
Okay, yeah, thank you very much. Thank you. So who is helping us with this? This is our patient. We've been asked to see them. Or you had a call overnight that this is the patient. They brought them in the evening time. They had road traffic accident. They broke that 3 to 5th rib. They have background bronchostasis. Yeah. Let me see. NC is nasal cannula. Those tiny stuff that goes to patient nose, nasal cannula. Sorry for my abbreviation. Sorry for that. So they broke their 3 to 5th rib. They are on 3 liters of oxygen via nasal cannula. They can't clear secretion. They are in pain. They are slumped in bed. So how do we help them? How do we help them? What can we pick up from their background?
Okay. Let me see. When I've gone through the case notes, then I'll take the vitals. I'll check the vitals for the patient. And then I'll also do auscultation. Since he has a bronchitis, I'll try to do auscultation and find out the areas that have maybe reduced the breath sounds and things like that. Then after that, I will also try to check the x-ray and confirm the rib fracture.
Yeah.
Then I think that's the far I can go, how far I can go. And then I'll try to change that position.
Yeah.
Maybe get some of the nurses and the other staff to help me if I'm alone or my colleague to change that slumped position.
Wow.
And then I'll also ask for the level of pain.
Yeah.
Try to find the level of pain so that I'll document the initial pain level when I've started. I think that's for now. Let me stop here for now.
Yeah, thank you very much. Thank you very much. Thank you. Really, really good stuff. Really good stuff. Yeah, being able to identify that this patient is slumped in bed. We need to put them in that upright position in bed. Because we know, again, we have said this several times today, that getting them upright in bed, again, from pain management point of view, it's going to help their pain indirectly. From chest management point of view, it's going to help their chest. It's going to help their FRC. It's going to help their tidal volume. In terms of clearing the airway as well, it's going to help them. If you are in a poor position in bed, if you are in a poor position, it's gonna be difficult for you to generate that expiratory flow normally, even if you don't have chest fracture or anything or rib fracture or anything. Great stuff. I love that. Thank you very much for that. And again, being able to say, yeah, you may, because somebody in pain, do you not just start just dragging them in? No, being able to say, yeah, I need nursing staff, I need my colleague if I'm alone. I'm sorry, I need nursing staff if I'm alone. I need my colleague, I need somebody to help me to get them upright in bed. Is also, in fact, I would say from compassionate point of view, 100%. From professional point of view, 100%. We are not laborers. We shouldn't be dragging and be no. Good stuff. Thank you very much for that. And again, being able to say, yeah, I will look at the chest X-ray. They are coming from bronchostasis background. Check their chest X-ray. Look at what impact in terms of refracture. I will be able to identify in terms of if there is any complication, blah blah blah. If there is any collapse, anything we can pick up on the X-ray. We can also pick it up from the X-ray. Really good stuff. Really good stuff. Yeah. In terms of pain, saying you will rate their pain, you also pay attention to their pain. It's also very great. We don't ignore that pain. We cannot ignore it. Yeah, really good stuff. Thank you very much for that. Yeah, can we have physios to speak on these things, please? Physios, please. How do we help this patient? Thank you very much for that. Yeah, PT Grace, go ahead. Yeah.
Okay, so if we are to go by the Trumbull score, if we want to use the Trumbull criteria, so this patient is 62, so probably give him a score of 6. Then the number of ribs fractured is 3. Then we have a chronic lung disease present. They did not know anything about his SAT. They just know that he's on international oxygen. So if I'm working with the scores, we have 635. That should be about 14. So now if we go to that Stumble score, it should be in the middle one, score of 11 to 25. So now that says that we need to assess in the first 72 hours and that we need to see like do respiratory assessment, mobility, upper limb review, advice and education. So bearing that in mind, our line of management will be in tandem with the Stumble score and what we are seeing with the patient. Thank you.
Oh, wow. Thank you very much. Thank you. Super great stuff. Really important stuff. Thank you very much. Stumble score. Go back to your Stumble score. Chat that score. Chat them. Put them on their Stumble score. Oh, bronchostasis. That's a poor respiratory background. Oh, 3 to refracture. How many ribs involved? Score that thing. The level of anticoagulants. Score that thing. What is their age? Score those things. And I said, oh, are they going to be maybe 0 to 10 or moderate this thing, or is going to, this thing will guide us. This thing is going to guide us to know, yeah, if I need to, and again, being able to identify that this patient needs to be on your case load for the first 42 hours of the admission is the top of it. They need physio, If you don't go in to see this patient, before you know, 3 liters might become 4 liters, 4 liters might become it might become 30% FiO2. It might be like, what am I even saying? It might become 60%, it might become 40%, 60%, 80%. They might end up in ITU, they might be intubated, they might have ET tube, they might be intubated, might be sedated. They might die, they might stay alive. Why? Because there's no physio intervention. Or they have physio intervention, but not effective physio intervention, or no physio not doing their job properly. Don't misconstrue me. We can have other team not doing their job well as well. But we don't know what they are doing. We don't know their job. We are talking about our own job here. Our own job here, not other people's job. Our own job here. It might be because physio not doing their job well. They might end up, patient can end up anywhere. They can die because of many reasons. Yeah. But our own job is what we are talking here, because we want to be doing our job appropriately. Yeah. So chart those scores, look at their risk, the risk stratification. Do that thing and say, yeah, and swam into action. Bronchostasis. This is a poor respiratory background. It's going to impact their new, now on top of their poor respiratory background, now they now have something severe pain. Again, life will be much more difficult for this patient. How do we help them? Let me get more physio. Please, physio, please talk. Please, physios, please talk. Do something. This is our patient. How do we help this patient? Physios, please, please. How do we help this patient? Do something. They are in pain in bed. They are slumped in bed. They are on 3 liters of oxygen. They have broken their 3 to 5th ribs. They are coming from poor respiratory background. How do we help them? Please. What are we be? What kind of things should we be doing with them in the bedside? Yeah, please, physios. Who is there? Who is helping this patient? Who is helping this patient, please? Please, please, please. Yeah, we've had 2 lovely physios. They have spoken great stuff, important stuff. Yeah, any other thing else from physios? Looking at our what do you call it now? Our toolkit, our box, our treatment box. What have we got in place to support this patient? What have we got in place? With MDTs, who are we speaking with to help this gentleman? Gentleman, what are we doing to help this gentleman? Please, what are we doing, physios? What are we doing? Physios, do something, do something, do something. Who is helping this patient? Let's just do this one. Let's do this one. We can go because of time. Yeah, but I would like us to track this one down. Some other ones and some other case studies that we've not answered. Maybe we can find a time we can put everything together and we can have a discussion on those, because case study is one of the best ways to learn, to have that nice and lovely clinical reasonings. So who is helping this gentleman? Pop response, chat box, open your mic. Please, please, please.
Yeah, then another thing we have to be sure of is that the patient is on analgesic. Seeing this as severe pain. If not, then we'll have to escalate to the physicians.
Yeah, thank you very much. Lovely stuff. I've been patiently waiting for that. Nigerian physios, are we going to ignore this patient's severe pain? With the patient's severe pain, even positioning in bed might even be difficult. Even attention, giving us attention might even be difficult. Are we going to ignore that? No, they need pain. They need strong analgesia. We need to speak. We need to speak with the medical team, please. Optimize their pain. What pain medication are they on? Is there scope for pain escalation? And again, why they are doing this thing again? Of course. And again, let me also say this. You can also find some patients again that also overdose in pain medication. If you overdose somebody on morphine, again, somebody can also go into respiratory. They may start feeling drowsy. Even if care is not taken, some people might even go into respiratory arrest and also die as well. So we are thinking about, you are looking at your patient, giving them what they want, monitor them. You are not the only, there is not just the responsibility of doctor. I can count many times that I've seen a patient, I will just go and meet them and say, I'll look at their pain medication they are on, I will look at their brand and say, you guys, you have to reverse, you need to reverse this patient pain medication, or you need to stop some pain medication, oxycodone, morphines, and something. Find another one that is of less side effects. Because if this respiratory, and again, you are also thinking about doing your own stuff, facilitate them on time. Do your own stuff. By the time they start moving around, they start moving the family member on the ward or something, they will start thinking less of the pain. And again, what does that mean? Less pain medication. What does that mean? We have started planning discharge with them. All right, thank you very much for figuring that out, PT Stella. That's really, really lovely of you. Thank you for that. This patient needs pain medication. And again, from compassionate point of view, this is what we can offer. Our TENS is useless here. Our infrared, our ultrasound is useless. Be lovely with them at the bedside. If you can, get their family members to also support them. It's not, if somebody is in pain, you can't just ignore. We can't, no. Get family member to support them. Get family member to show that compassionate care. Physio is a lovely job. Get people to support them. All those kind of things. Speak with the nursing staff to give them regular pay. In fact, I will normally document in my note, nurses word for regular PRN medication, because I know this is really very sore. It's going to be painful. You've got nerve, intercostal nerve up and down, your vascular distance in the chest. Anytime you breathe in and out, that chest wall will keep irritating the nerves. And more pain for you. This is why this thing is really, really very sore, very painful. And some people might even have irritation of the pleural, viscera, or whatever, that will even cause more pain. So this is why these people need, I will normally document and I will normally speak, advocate for my patient. Please, regular pain medication, regular. Every time they ask for it, give them. And again, while they are giving them, you are watching, you're also asking them what's their response to the pain medication. You're also watching, and everybody is watching. Thank you for that. I love that. Thank you, really, really, really. Thank you for that. All right, pain medication, PT. Ibrahim also mentioned that. This stuff, yeah, physio stuff. PT. I'm struggling to pronounce that first name. Sorry. PT Ibrahim. Pain medication, chest clearance. How do we help them? He just mentioned now. PT Ibrahim, our lovely physios now. He has mentioned that now this patient needs chest clearance. Why? Don't forget it's coming from poor respiratory background, bronchiostasis. Now they are now struggling with poor cough. They cannot take in good deep breath. They cannot cough. They are doing pain. They are avoiding cough. They are avoiding to cough because of their pain. Chest clearance. So how do we help them to clear their chest? This is the issue now. How do we help them to clear that? Yeah, chest clearance, 100%. But how do we help them to clear their chest? And positioning, thank you, PT. Yeah, positioning could be one of those things we can use to help them to clear their chest. Positioning, upright position. I'm not saying PD, postural drainage, but not those ones. Somebody going in pain, do you want to tilt their bed upright? Well, what kind of physio this thing is that? Get them upright in bed. Get them to have that lovely tidal volume. Get them to sit out. Get them, all those things. They need it. They need that position in bed, even if they cannot leave if they cannot leave the bed. They need that upright position in bed. Yeah, asking them to do gentle, deep breathing, gentle coughing. If they can, even if they cannot cough, getting them to something to spring their chest, to support their cough, their chest, to brace their chest. Why they want to cough? If they need to do deep breathing, you can still do your regular ICBT or something. If they are able to do, you can still do it. Suctioning, yeah, suctioning, 100%. Thank you, PT Ibrahim. You can suction them. Even with your suction, you can use suction to trigger their cough. If you pass yanka, if you stimulate, if you irritate their hair with yanka, can make them to cough again. You can ask them to brace their cough, and you explain all these things to them. Before you do it, you reassure them, you encourage them. All those things, these are what they need. All right. And again, 3 liters is not too bad for me. To get them out of bed, if the pain is well controlled, I can get them out of bed. I need to be thinking about that. Top of my skills, get them out. 3 liters. 3 liters is not bad for me. Get them to sit out in chair. Get them to do hourly deep breathing exercises. Okay, and again, think about that stumble score. This patient needs to be well. Again, bronchiostasis. They might need nebulizers. Normally, even before they come to the hospital, they might even be struggling with secretions, airway clearance issue, blah, blah, blah. You've got good reason to speak with the medical team, get them nebulizers, regular nebulizers on the ward. All those things. Thank you, PT Grace. They need thoracic coughing, yeah, bracing with hands or pillow, great. Nebulizers, hypertonics and inhalers, 100%, great stuff. And get them out of bed if they are able. 3 liters is not an excuse for physios to get this patient out of bed. Tell your colleagues, support them in bed. You can do bracing. Think about how you now need to get them even to sit at the edge of bed. Think about that. It might be somebody, you might need somebody, maybe your colleague now. Brace your chest with pillow. Let's roll side. Let's assist them. Go gently. All those things. Think about those things. You get them up, edge of bed. Think about it. Pay attention to their pain. Reassure them. Distract them. These are what you need. Get them to sit in the chair if they are able. These are what you need to support them. All right. Now, because of their background now, I might also be thinking, if their chest rise is also really very poor, they are having teeth secretions. And also be thinking, do I need escalation in them? For bronchiostasis, somebody coming from background of bronchiostasis, and I now start thinking, even if I need to escalate this patient now, on what? Is it going to be cough assist? Is it going to be this? Is it going to be that? And I also need to look into, are there anything around, maybe, what do you call it now? Around contraindication to my positive pressure, if I need to use that with them because of their background of bronchiostasis, because their lung might be fragile. But on top, even if we don't have that now. We don't have that. Of course, we are still praying to have those things. What can I do if this patient is presented in my facility? I will do everything we have explained, optimize their pain, give them, reposition them upright in bed, get them out in bed, get them to be sitting. And you might not be able to mobilize them first day, For second day, third day, what am I planning? Am I planning on how to stand them, how to ask them to do deep breathing in standing, how to ask them to do marching on sports, how to ask them to progress mobility? Now, and they are, while I'm doing all my physios, they're also on regular pain medication, regular, what do you call it? Regular nebulizers, all those things. All those things. And if they are not, all those things are not being helpful, I will now start thinking of escalation plan from my physio perspective. Think about all these things. So I'm going to stop here today because of time. Thank you very much. Yeah. Go ahead, open your mic, PT Messi.
Good evening,
Yes,
sir.
please.
Yes, sir.
I have a question.
Yeah, go ahead.
Okay, sir. I have a question.
My question. Yes.
Go ahead, ma.
Okay, my own is I want to. I don't know if you can recap some of the lectures you gave, because I was logged out around the time you were explaining about fracture of the first rib to check the upper limb range of motion and things like that. And then when I rejoined, it was when you have already finished explaining the rib fracture score. So I think I missed a lot of things in between. If you can just help me to go through that part.
Okay, thank you very much. Because of time, it might be really very difficult, and I'm sorry that the network actually logged you out. But I think these videos will be on the YouTube. In my what maybe rechecking them. But what I mentioned just briefly, what I mentioned under that is for the refracture, for the first refracture, because of neurovascular bundles that passes through that is very that is in close contact with the first rib. So there might be subclavian artery or subclavian vessels being impacted. There might be brachial plexus being impacted, something like that. So we have good reasons to check sensations, to check range of motion in their shoulder, all those kind of things. Check their upper limb movement if there is no contraindications, all these kind of things. Check, in fact, do some. You might also want to do some. What do you call it? You might also want to do some range of motions to the scapula, all those kind of things, scapular exercises, all this retraction, protraction, if when they are able. But in the first instance, your goal will be optimizing their chest, optimizing their pain and all of this. But that may also be part of your rehab plan with them. So depending on which nerve is affected, as per brachial plexus injury now, I also now think about, how do we support them? But initially, your goal will be chest, optimizing their chest. Then while you are doing that as well, you're also doing some gentle active range of motions as pain allows, sensation, all those things, as pain allows, and regular physio that we do with patients. So I'm sorry, I may not be able to go in depth because of. But
sir, I have a question, sir.
Yeah, go ahead, ma.
Yes, sir. My question is, I know that in limbs, like in lower limbs, when someone has a fracture, over time you wait for the fracture to heal. That's true, and like you also incorporate reduction. That's if the fracture is closed. But in the case of these ribs now, like, is it that you also wait for the ribs to heal, like, or a surgery will be carried out? How will the fracture be healed?
Okay, generally speaking, physio-wise, we don't have to wait for the ribs to heal. The reason for the lower limb, for instance, is because lower limb is a weight-bearing, weight-bearing limb. I mean, our joint or something, we've got some weight-bearing joints in lower limbs. But for the ribs, because of the risk associated with the ribs, we don't have to wait for the ribs to heal 6-12 weeks or something before we start doing something. In fact, the patient might not even live up to that time. Some might even die because that is directly linked with the breathing, respiration, and everything. So we don't have to wait. So we need to see them day one when they are in the hospital. If they are admitted today, we have to see them today. That is what guideline says. Now, regarding management of the refracture, normally what you will find is conservative management. The medical team will normally not do anything. They will just optimize their pain medication. But some of them might, if they have associated injuries like sternal fracture or something, or maybe fracture to the upper limb, that is what they will rather start taking care of. But some of them, again, might also be needing surgeries, like they might need to put Ori for something, like put something in the, but you may, in fact, I think I've only seen maybe 1 or 2 of that, but usually what you will find most of the time is going to be conservative management. They won't even do anything. So they will just ask them, physios, do your job, mobilize them, optimize their chest, payment optimization, and that's it. But they need to be seen day one. We don't have to wait until it might be too late. It might be too late. In fact, we might not even end up seeing some of them if they are waiting until they are ready. This thing is, might not even see, we might not even see some of them because they might die. So that's why we need to be seeing them. I don't know if I answered your question, ma.
Yes, sir. Yes.
All right, thank you very much. So in the absence of
I do have a question too.
Oh, okay, ma. Go ahead, ma.
Please, can you explain better the positioning you talked about during the management?
Oh, okay, the position during the management. So generally,
like just explain, yeah.
Okay, yeah, okay. So generally, like I've been saying, respiratory wise, like chest wise. So we normally, this thing can be explained generally with lung volume, but just believe me because of time and for now. So patient that is standing generally, let's go first of all with that. Standing patient is better than patient sitting. Sitting patient is better than patient lying in bed. Now, so in terms of positioning of this patient, somebody that have got refracture, we cannot tilt their head downward. We cannot do this thing we call Trendelenburg or posterior drainage, this thing position with them in bed. They won't be able to tolerate that. And again, when it comes to what matters most, what really matters most in patient with refracture is, to us as physio, 2 things: being able to increase their thoracic expansion, being able to take in deep breaths when they increase their thoracic expansion, and being able to clear their airway. Those are the 2 or 3 things that matters to us. So now, what position will generally be the best position for them? It's going to be upright position. So if they are in bed, so what I want to do is, again, I'm sorry for diverting again. Again, this is where physios need to do some of their job again when it comes to manual handling. Some of our bed in our hospital again is difficult for us to put this patient in this position. Some of our bed in this hospital, in some of our hospitals. But in a way, what we should be thinking about is getting them upright. If they can tolerate, get them to sit in the bed. That cardiac, here they will say cardiac position in bed. Get them to sit up as much as possible in bed, as pain allows. Because some people might not be able to tolerate that cardiac position. Some people might just be this thing we call semi-infrared, 30 degrees, this thing in bed. Put them in that position as pain allows. Because you are looking at 2 things now. You are putting that pain into consideration. And you also know the benefit of what that position will do to their chest. Because getting them into appropriate position means indirectly that will put diaphragm in good position to be able to descend. Indirectly, that will make it easy for their chest to be able to rise up and down. Indirectly, directly, that will make air to be able to fill into their lungs easily. In terms of pain management, their body will naturally start tolerating pain gradually in normal position than unusual positioning. But you might find people screwed, like not in a normal position because of pain. Their body is just torn anyhow in bed, and these are not our regular positioning. Our regular positioning is fundamental positioning: standing, walking, sitting up. All these are normal, natural position. So getting people back into that natural position is a way of gradually building their tolerance to pain. And again, chest-wise, it's going to be more easy for their thorax to rise up, to be able to do deep breathing in and out. And again, in terms of alertness, getting somebody into more appropriate position in bed is also a way of facilitating their level of facilitating their level of alertness in bed. Because if people are slump in bed, it's quite easy for them. Don't forget, their thoracic expansion might be poor. They might start retaining CO2. They may start also losing their level of consciousness. They might start going into what do you call it? They might start losing their level of consciousness. So good position is just tilting the bed up, bring the head of the bed, bring it up, get them into that nice and upright position. If we don't have that bed in the facility, we can think about using pillow to support them sideways, the pillow we've got on the ward, or ask the family member to bring pillows, support them, get them, just find a way to support them, be able to sit up a bit, even if we don't have that kind of bed. But again, at the same way, there is no excuse. This is 2026. There is no excuse for us in Nigeria not to have those hospital beds, like standard hospital bed. We do not have any excuse. There is no excuse for us. Nigeria is not a poor country, but there is no excuse for us not to have those kind of beds. So this is also part of our duty as physio, to advocate, to speak. Manual handling is a core physio domain. All these hospital beds, all these having necessary equipment on the ward to move patients up and down is our job. But we are not doing it. We are not doing those things. So it is our job to advocate for the hospital management to do some certain things. Let's start thinking about getting people to be able to do some of these things. All right. I don't know. Did that answer your question, Ma, because of time?
Yes, sir. Thank you.
All right. Yeah, that's it. All right. Any other question?
Yes, sir. Just one more.
Yes, ma'am.
Okay, so for the pediatric population that you're talking about, you said the bad lung up does not work. So I'm wondering if a child has like lung collapse in, let's say, the right lung, and we place the right lung in dependent position. Now, will that right lung be ventilated? Like, will air be able to like inflate that collapsed lung?
The thing is this, it's not like a general, like it's not like 100% it doesn't work. No. But what I'm trying to say is we need to be aware that sometimes you might put some pediatric child, some children, or you can put them in that position and they will start desaturating. For instance, if I want to treat them, let's say I want to percuss them, I want to do shaking, respiratory valves, and all of these things, I still need that bad lungs to be up for me to be able to assess their lungs, for me to be able to prepare, for me to be able to percuss them. That bad lungs still need to be up. But why that, I will first reposition them. I will first put them in the sideline so that I can get access to that bad lungs. So if I put them in that position, it is my responsibility as physio to look at their ups at that moment, to look at their work of breathing, how they are presenting, because some of them might desaturate. Because in the long run, or if I'm not just like adults, now let's say adults have had lung collapse, I might just leave them in bad lungs and go away and say, yeah, nurse, monitor the rest, I will leave them. What I'm saying is, it might be dangerous sometimes if you just put pediatrics in bad lungs and you just say, yeah, nurse, do the rest, I'm going, physio, I'm going, bad lungs up, I'm going, I've done my job. No, be aware that it's just a kind of awareness, caution, like, oh, you might do that. It might work on some people, from some ped population, it might not really work for some people. Because the reason being that the other lung, the good lung that you put in that dependent position can also be squeezed because of their thoracic cage still developing. I don't know if that answers your question, Ma. Hello?
Yes, it did. Thank you, sir.
Right, yeah. It's just a kind of caution to be aware. I can put adults, bad lungs up and go. Even some adults, some adults also react to it. But generally for adults, I can just do that and go. But for peds, take caution. Take caution. It might work, it might not work for some people. So that's that about that. Any other questions? Any other questions before we go? Any other question? Thank you very much. It's really been a lovely time with us today. Thank you very much. I really appreciate our commitment to sharing knowledge, learning from each other. We are all learning, honestly. We are all learning, which is great. And commitment and everything. So thank you very much. By the grace of God, we'll catch up again next time. Thank you. Have a lovely time.
Thank you, sir.
Thank you, sir.